In the next 1 hour, I will take you across through three important systems in pharmacology, that is cardiovascular, endocrine, and blood. So the learning objective of this session, at the end of this session, second BDS student shall be able to enumerate the mechanism of action, therapeutic uses, and ADR of at least the prototype drugs used for the treatment of various cardiovascular, endocrine, hematological disorders, which are included in the pharmacology immunity dental syllabus. So we start with the cardiovascular system. First, the anti-anginal agents.
Good morning.
Angina pectoris is a pain syndrome which is characterized by severe substernal pain that radiates to the left arm. The main cause of angina is imbalance between the oxygen supply and the oxygen demand. Therefore, strategies to treat angina basically improves the balance between this oxygen supply and oxygen demand. Now, there are various determinants of oxygen supply. First is afterload, which is mainly determined by the arteries. Vasodilatation of the arteries will reduce the afterload and increase the oxygen supply. The determinants of oxygen demand include the heart rate, the force of contraction. The determinants of oxygen demand include heart rate, contraction, and preload. Preload is mainly determined by the veins. So drugs which cause venodilatation will reduce the preload, and also drugs which reduce the heart rate, force of contraction will reduce the oxygen demand. Therefore, anti-anginal drugs will either reduce the oxygen demand or they will increase the oxygen supply and therefore will be useful in angina pectoris. Now coming to the classification of the drugs used in angina. So there are 4 important classes: nitrates, calcium channel blockers, beta blockers, potassium channel openers. Now out of this, nitrates is the prototype drug, which is conventionally used for the treatment of angina. Now when we talk about nitrates, there are several nitrates, out of which you have glyceryl trinitrate, which is also known as nitroglycerine, GTN, and isosorbide dinitrate. They are available as sublingual tablets. For oral, we have isosorbide dinitrate and mononitrate, which are used for prophylaxis of angina. Coming to the mechanism of action, how these nitrates act. Now these nitrates are converted to nitrites. These nitrites are rich in nitric oxide. So they release nitric oxide, which activates the guanyl cyclase, which is present in the vascular endothelium. So there is an increase in cyclic GMP, which activates the protein kinases, and there is dephosphorylation of myosin light chain kinase, which is present in the blood vessels. So there is vasodilatation of both the arteries and the veins. When we talk about nitrates, it mainly causes vasodilatation of the veins, so the preload is reduced. And as we had discussed, when the preload is reduced, what reduces is the oxygen demand, and that is the objective in treatment of angina. Now, important pharmacokinetics, glyceryl trinitrate or nitroglycerine is administered sublingually. So for the treatment of acute attack of angina, GTN is given sublingually. It has a quick onset of action and a short duration of action. It is highly lipid soluble, and therefore as a sublingual tablet it is effective. Adverse effects with nitrates: headache. Okay, these are all vasodilators, so they will cause dilatation of the cranial blood vessels, causing headache. There is postural hypotension. There is a reflex tachycardia which occurs. And on a long-term basis, tolerance develops with the use of nitrates. Certain drug rashes have been reported with the use of nitrates, and these drugs should be tapered, otherwise there could be withdrawal syndromes. Therapeutic uses of nitrates: For acute attack of angina pectoris, we have glyceryl trinitrate or isosorbide dinitrate, isosorbide mononitrate, and oral dinitrate are used for prophylaxis in all types of angina, whether it is stable angina, unstable angina, and variant angina. Because of its vasodilatory properties, IV nitroglycerin is used in the treatment of congestive cardiac failure. Again, for the healing of the ulcers, again vasodilatation is caused by these nitrates, so they help in the healing of the tropic ulcers. They have smooth muscle relaxation properties. So various colic or pain which is because of spasm, biliary, ureteric and renal colic, there also nitrates are effective. Cyanide poisoning. Okay, here amyl nitrate and sodium nitrite, they are indicated for this type of poisoning. These nitrates, they convert hemoglobin to methemoglobin, and we know that cyanide has a higher affinity for methemoglobin. It forms cyanomethoglobin, which can be easily excreted when IV sodium thiosulfate is added. So these are the therapeutic uses of nitrates. Then we come to the next class of drugs, that is calcium channel blockers. There are three subclasses: phenylalkylamines, benzothiazepines, dihydropyridamines. The prototype drugs being verapamil, diltiazem, and amlodipine, nifedipine under dihydropyridamines. Now, when we talk about calcium channels, they are either present in the smooth muscles, that is in the blood vessels, or in the heart. We know that in the smooth muscles, calcium has a role to play in smooth muscle contraction. And in the heart, it plays an important role in myocardial contraction. So when we block the entry of calcium, it will cause smooth muscle relaxation, causing dilatation of the arteries and the veins. When we talk about calcium channel blockers, they are mainly dilators of the arteries. So they will reduce the afterload, because of which the oxygen supply is increased. When we talk about the action on the heart, when the calcium channels are blocked in the heart, there is a decrease in the heart rate and the force of contraction, which reduces the oxygen demand. Okay. Now these calcium channels may be present in the heart as well as in the blood vessels. Verapamil is mainly effective against calcium channels which are present in the heart, whereas the dihydropyridamines, nifedipine, is mainly effective against calcium channels which are present on the blood vessels. Okay, so this is one important difference besides being in different subclasses of the calcium channel blockers. Another major difference is the action on the heart. Verapamil, because it is mainly acting on the calcium channels present in the heart, it will reduce the heart rate. Whereas nifedipine, because it's effective mainly against the calcium channels in the blood vessels, it will cause vasodilatation and there will be a reflex tachycardia. Okay, so these are important differences between the three subclasses of calcium channel blockers. What are the adverse effects of calcium channel blockers? Okay. So they cause hypotension. Okay. They are vasodilators, so postural hypotension, flushing, headache, ankle edema, which is pitting in nature. Okay. There is constipation, its action on the GIT. Digital dysesthesia, so the digits become super sensitive, highly sensitive. And depending upon the calcium channels blockers, whether if it's verapamil, it causes bradycardia. If it is nifedipine, it can cause tachycardia. Uses of calcium channel blockers, mainly for prophylaxis of angina pectoris. They are used for all types of angina. Now, action of verapamil on the heart is to reduce the heart rate, which is exploited therapeutically in supraventricular arrhythmias, where the heart rate goes up. So verapamil can reduce the heart rate. In hypertension, amlodipine, this drug causes vasodilatation and hence reduces the blood pressure. Okay. Then verapamil, then nicardipine are all used for prophylaxis of migraine. So these are the important uses of calcium channel blockers. Coming to the third class of drugs, the beta blockers. So remember, in angina, beta blockers mainly have the hemodynamic benefits. Okay, so they will block the beta-1 receptors which are present in the heart, and we know that beta-1 receptors basically mediate increase in heart rate, force of contraction and velocity of conduction. And initially we had discussed that oxygen demand is determined by the heart rate and contractility. Since these drugs reduce heart rate and contractility, they will reduce the oxygen demand. Okay, so they are mainly useful for prophylaxis of angina. One important point here you have to remember is that they are contraindicated in variant or the Prinzmetal angina because they cause unopposed alpha-mediated vasoconstriction. So the principles of management, very briefly, acute attack you all have to remember. You have glyceryl trinitrate and isosorbide dinitrate sublingual tablets for short-term prophylaxis to prevent any exertion. Okay, like you want to climb uphill. There, for short-term, you can use nitroglycerin sustained release tablets or transdermal patches are there. For long-term prophylaxis, beta blockers are the drug of choice. If not controlled alone with beta blockers, you can add drugs from different classes, whether it is nitrates or even calcium channel blockers. Okay. Now coming to the must-know questions under this topic, rationale for using GTN in angina pectoris, nitrates, routes and preparations which we have discussed, why beta blockers are contraindicated in variant angina, calcium channel blockers, short note, and LAQ, classify anti-anginal drugs, write mechanism, uses and ADR of GTN. Okay. So with this, now we move on to the second topic under cardiovascular system, that is anti-hypertensive drugs. We know that hypertension is sustained increase in the blood pressure, which is systolic more than 140 and diastolic more than 90 millimeters of mercury. And based on the JNC guidelines, which is their Joint National Committee guidelines on the prevention, detection, evaluation and treatment of hypertension, we classify hypertension into stage 1 and stage 2 depending upon the systolic and the diastolic blood pressure recordings. Now, which are the anti-hypertensive drugs? Okay, so as a LEQ, classification of these drugs are very important. Okay, so we'll just go through the different classes which can be used for the treatment of hypertension and then discuss in detail regarding the first line drugs. Okay, so the array of drugs which can be used for treatment include diuretics. You have thiazide diuretics, okay, which are mainly preferred. Then you also have high ceiling furosemide, direct renin inhibitors like aliskiren, angiotensin converting enzyme inhibitors, ACE inhibitors, captopril, lisinopril and allopril, angiotensin receptor blockers, losartan, valsartan, centrally acting drugs like clonidine, methyl dopa can be used. You can also use blockers for the adrenergic system like beta blockers. You have metoprolol, atenolol, or you have alpha blockers like prazosin. Both alpha and beta blockers can also be used like labetalol and carvedilol. Then under calcium channel blockers, we have verapamil, nifedipine, amlodipine. Conventionally, ganglionic blockers were used. Okay, the use has declined, but drugs like trimethoprim were earlier used. Then vasodilators, if they mainly act on the arteries, they reduce the afterload like hydralazine, minoxidil, or it could dilate both arteries and the veins like sodium nitroprusside. Now under this, we should all be very familiar with the important first line drug for hypertension, that is ACE inhibitors. Okay, so a quick recap, angiotensinogen pathway. Okay, so angiotensinogen is converted to angiotensin 1 with the help of the enzyme renin. Now this angiotensin 2 is then converted to angiotensin 1 is further converted to angiotensin 2 with the help of the enzyme ACE. Now this angiotensin 2, once it is produced, has several detrimental effects, like it's a potent vasoconstrictor, so it will increase the blood pressure. Similarly, it will cause release of aldosterone. Aldosterone we know causes sodium and water retention. This can further contribute to the rise in blood pressure. Then angiotensin 2 also reduces bradykinin levels. Bradykinin levels, these bradykinins are potent vasodilators. These angiotensin 2 also causes increase in central sympathetic discharge. Okay, so by various mechanisms, they can all contribute to the increase in the blood pressure. So when you give ACE inhibitors, they will block the enzyme angiotensin converting, okay, enzyme that is ACE, and as a result, They will reduce the sympathetic discharge, they will increase bradykinin levels, they will inhibit vasoconstriction, and they will also reduce the sodium and water retention. All this contribute to the fall in blood pressure. Okay, so it's not only through inhibition of vasoconstriction, but you are also supposed to write the various other mechanisms. Okay, how ACE contributes to its hypotensive effects. Now, the ACE inhibitors which are used clinically, lisinopril, enalapril, ramipril. Okay, so what are the adverse effects? We said that ACE inhibitors, they increase bradykinin levels. Now, because of increase in bradykinin levels, there are several adverse effects like cough. Okay, then there is angioedema, alteration in taste. Okay, so these are all attributed to increase in bradykinin levels. ACE inhibitors, they cause release of aldosterone. Okay, therefore there is hyperkalemia, which is seen as an adverse effect. They are vasodilators, so naturally they will cause hypotension. Okay, then alteration in taste, they are all teratogenic. Okay, so we have to remember, although ACE inhibitors are the first line drugs, they are not safe in pregnancy. Okay, so important contraindications for ACE inhibitors: hypersensitivity, hyperkalemia, pregnancy, renal artery stenosis, bilateral renal artery stenosis, they are not to be used. Now coming to the uses of the ACE inhibitors. Okay, so hypertension, which we already discussed, congestive cardiac failure. Now they have become very promising drugs. Okay, they are used, they are mainly indicated because they also reduce the progression of the disease. We'll discuss this in detail later on. In myocardial infarction, within the first 24 hours, ACE inhibitors have been shown to reduce the mortality which is associated with MI. Then in certain high-risk patients, okay, who have cardiovascular risk, okay, ACE inhibitors have been known to reduce the incidence of stroke, okay, and they are nephroprotective. They reduce albuminuria. Okay, so in diabetic nephropathy also they are indicated. So the management in brief: stage 1. Okay, so you have mainly 4 drugs which we start with. Okay, you have either ABCD, ACE inhibitors, B for beta blockers, C for calcium channel blockers, D for diuretics. Okay. Beta blockers is mainly preferred in the younger patients, whereas calcium channel blockers and diuretics in the older patients. Okay, so you start with the monotherapy. The first line drug is now ACE inhibitor. If there is a partial or no response, then you have to add another drug, okay, from a different group, okay, so that there is some added advantage. In stage 2 hypertension, okay, we generally use combinations of drugs for their synergistic actions. It could be ARBs and diuretics, ACE inhibitors or diuretics, okay, beta blockers or diuretics. We can also go for a 3-drug combination depending upon the response. Special subgroups: hypertension in pregnancy. Okay, so which are the safer drugs which can be used? You have hydralazine, methyl dopa, cardioselective beta blockers can be used. In case of hypertensive emergency, systolic more than 220, diastolic more than 120, medical emergency. So here sodium nitroprusside is a drug of choice. It's a vasodilator. It reduces, okay, both preload and afterload, and therefore there is a marked fall in blood pressure. We can also use GTN and esmolol. Okay. Now must know questions under this topic: ACE inhibitors. You can also be asked about drugs acting through the renin-angiotensin system. Okay, so in this you will also have to write about the renin inhibitors, the angiotensin receptor blockers, the ACE inhibitors, and also mention about beta blockers, because beta blockers, they inhibit the release of renin. Then sodium nitroprusside, that is hypertensive emergency, maybe as a MCQ or sometimes as a subpart of SCQ it can be used. Diuretics, thiazide and loop diuretics. You should know the mechanism, uses ADR. As a class, calcium channel blockers and beta blockers. Okay, as far as LQ is concerned, this is a always asked in the exams. Classify antihypertensive drugs. Favorite question. To write the mechanism uses ADR of ACE inhibitors. It could also be calcium channel blockers or beta blockers. Now we move on to the third topic under the cardiovascular system, that is cardiotonic drugs. We know that congestive cardiac failure is a contractile dysfunction. So the heart is unable to pump adequate blood. So it does not provide adequate blood supply to meet the oxygen demands of the body. So the net effect, what happens in congestive cardiac failure is a decline in cardiac output. So when there is a decline in cardiac output, there is a compensatory mechanism by the body. That is, it increases the sympathetic discharge. There is increase in heart rate. Okay, and at the same time, when there is decrease in renal blood flow, there is increase in renin release. As a result, it increases the angiotensin 2 levels. When angiotensin 2 levels are increased, there is also accumulation of aldosterone, which causes sodium and water retention. Okay, so the various drugs which are used in congestive cardiac failure is basically to target these abnormalities which occur in congestive cardiac failure. Okay, so there's a sympathetic discharge, so we'll use beta blockers which reduce the heart rate. Angiotensin 2 is elevated, okay, and this has detrimental effects because it increases the preload, afterload, the workload on the heart. So you will use the ACE inhibitors. At the same time, there is increase in aldosterone which causes sodium and water retention. So diuretics are used. Okay? And we know that the main cause in congestive cardiac failure is that there is a decrease in cardiac output. So inotropic drugs which can increase the cardiac output, they are used. So these are the four important classes in congestive cardiac failure. Okay. Now we will discuss about the cardiac glycosides. So these are basically glycosides which are obtained from the plant source. Okay, example of cardiac glycosides are digitalis, digoxin. Okay, now these have important property that they increase the myocardial contractility without increasing the oxygen consumption. So that's the important property of the cardiac glycosides, because of which they are widely used for the treatment of congestive cardiac failure. Okay. So digoxin and digitoxin are the important cardiac glycosides. Okay, so there are certain differences between these drugs. Like digoxin has a lower bioavailability compared to digitoxin. As far as the half-life is concerned, the half-life of digoxin is lesser compared to digitoxin, 36 hours compared to 5 days for digitoxin. The plasma protein binding for digoxin is also less compared to digitoxin. Now coming to the mechanism of action of these cardiac glycosides, these drugs basically inhibit the sodium potassium ATPase. Okay, now these sodium potassium ATPase are present in the cardiac cells. So once these sodium potassium ATPase are inhibited, there will be intracellular accumulation of sodium. Intracellular accumulation of sodium decreases the extrusion of calcium through the sodium-calcium exchanger. And as a result, there is also intracellular accumulation of calcium. Now, this increase in intracellular calcium will also cause efflux or influx of calcium from the sarcoplasmic reticulum. So, increased calcium will increase the cardiac contractility. Okay, so we discussed that in congestive cardiac failure, there is a decrease in increase the heart rate. Okay, otherwise the cardiac work will also increase. How? By increasing the vagal activity. Okay, as a result, the heart rate is reduced. Now, what are the clinical uses of the cardiac glycosides? Okay, so congestive cardiac failure, they are used. Then in various conditions where the heart rate goes up, like atrial flutter, heart rate is between 200 to 350, fibrillation more than 500 beats per minute, paroxysmal supraventricular tachycardia, okay, 150 to 200 beats per minute. So here cardiac glycosides, they have an important property that they can reduce the heart rate. So because of this action of the cardiac glycosides, it is exploited therapeutically and it is used for the treatment of fibrillation, flutter and paroxysmal supraventricular tachycardia. What are the adverse effects of cardiac glycosides? Okay, so they have prominent cardiovascular effects. Therefore, cardiac toxicity ranging from ventricular premature beat, AV conduction blocks, ventricular tachycardia, fibrillation are all seen with cardiac glycosides. GI toxicity, nausea, vomiting, diarrhea. Okay, so they are very significant with cardiac glycosides. And this is very important because these are the warning signs to the physician that the patient is going into toxicity. Okay, so this is something that should not be overlooked and should be taken seriously, when the patient is on cardiac glycoside and he develops the GI toxicity. Certain CNS toxicity like headache, fatigue, okay, can be seen. Ocular toxicity is peculiar with the cardiac glycosides. So there is alteration in the color perception. So there are halos around the objects which are seen when the patient is on cardiac glycoside. Treatment of congestive cardiac failure, I will not go into the details, but what we have to remember is that ACE inhibitors are now preferred. Okay, so they have become the first line drugs because they also reduce the progression of the disease. Okay, so in the early stages, the ACE inhibitors are used, beta blockers can be added, and in the late stages, okay, mainly we use the cardiac glycosides. Diuretics, depending upon the edema, are added, okay, for complete treatment. So the must-know questions under this topic: cardiac glycoside digitalis, mechanism of action, therapeutic uses. What is the rationale of using digitalis in congestive cardiac failure? Okay, then diuretics. Okay, loop diuretics are mainly preferred. Okay, why? What is the mechanism? Then ACE inhibitors. Okay, this we should all know in detail. As a LEQ, what can be expected? Classify cardiotonic drugs, write mechanism, uses, and ADR of digitalis or the ACE inhibitors. With this, now we come to the next system, that is endocrine, and we will start with the anti-diabetic drugs. Okay, so we know that diabetes is a metabolic disorder which is characterized by chronic hyperglycemia because of relative or absolute deficiency of insulin. Okay, so there are different types of diabetes clinically, but what is important for you, type 1 and type 2 diabetes mellitus. Okay, so in type 1, it is insulin dependent diabetes mellitus where there is destruction of the beta cells of the pancreas. As a result, there is absolute deficiency of insulin. So exogenously, you have to supplement insulin. Type 1 is mainly seen in children, and the incidence of complications of diabetes, ketoacidosis, is much more in type 1. Okay? And generally these children, they are lean and thin. Whereas type 2 has a genetic predisposition, mainly seen in adults, and here the cause is there is partial destruction of the pancreatic beta cells. Along with that, there is insulin resistance. Okay, although insulin is produced, but is not able to act. Okay, so these are the main causes in type 2. It has a genetic predisposition, and generally these individuals, they are obese. Okay, so these are the common types of diabetes which we encounter clinically. Then you also have gestational diabetes, okay, which is seen in case of pregnancy. Management of diabetes mainly includes insulin, or you can give the oral anti-diabetic drugs, which is known as the oral hypoglycemic agents. Okay, so I'll quickly take you through the important points under insulin. So there are various preparations of insulin which we should know. Okay, insulin is obtained from the source is the pancreas. Okay, so conventionally you have the insulin which is obtained from the pork and the beef, and now we have the human insulins which are prepared by DNA recombinant technology. Okay, so various preparations of insulin are available clinically. You have the ultra short acting insulin where you have insulin lispro, insulin aspart, insulin glulicine, okay, which has a short duration of action, around 3 to 4 hours, compared to the next, which is the short acting insulin, where you have the regular insulin, which has a duration of about 6 to 8 hours. Then intermediate acting insulins, that is neutral protamine Hegden, NPH. Okay, neutral because the pH is neutral. Protamine is the protein which is added, okay, to prolong the duration of action, and Hegden is the place in UK where it was discovered. So the name NPH. Duration of is about 10 to 20 hours. Then you have long-acting insulins, okay, like insulin glargine, insulin detrimer, okay, which have duration of around 24 to 30 hours, okay. Now, what are the indications of insulin therapy? Okay, as we discussed in type 1 diabetes, it's a must, okay, drug. In type 2, we can use oral anti-diabetic agents in combination with insulin. Then, in gestational diabetes, okay, most of the oral anti-diabetic drugs are teratogenic. Therefore, insulin is used, okay. Then to tide over the stress of surgery, okay, stress and emergencies, insulin can be used. In severe hyperglycemia, okay, to lower the blood sugar, again insulin can be given. Various complications of diabetes like diabetic ketoacidosis, hyperosmolar coma, okay, again insulin is the drug of choice. Now coming to the complications of insulin therapy, what are the adverse effects which are seen with insulin? Okay, so it's a double-edged sword because although it can lower the blood sugar, okay, too much of insulin, or if you've skipped the meal, you've taken higher doses of insulin, okay, it can cause hypoglycemia, okay. So hypoglycemia may cause autonomic symptoms, neuroglycopenic symptoms, and can be fatal to the patient if not, okay, treated at the proper time. Okay, so here dextrose 50% is mainly indicated in severe cases. In mild cases, no, carbohydrate rich either biscuits, chocolates can be given to tide over the crisis. Then insulin can also cause local allergic reactions. It can cause insulin lipodystrophy, okay, either atrophy or hypertrophy, okay, because insulin is taken subcutaneously. So therefore, it can cause these lipodystrophies. Okay, therefore, what is advised is you should alter the site, okay, where you are taking the injections every day. Okay, then insulin can also cause insulin resistance. So these are the adverse effects of insulin. Now coming to the oral anti-diabetic drugs. First, the classification. Okay, so for the treatment of diabetes, you have, it's such a common disorder now, and India is the diabetic capital of the world. So many patients are suffering from diabetes. Okay, so several drugs are available which have unique mechanism of action. Okay, you have sulfonylureas, where you have the first and the second generation, okay, like tolbutamide, clopropamide. Second generation is glibenclamide, glipizide, glicazide. Okay, the second generation, they are more potent. The adverse effects are much less, and they have shorter duration of action compared to the first generation. Then you have meglitinides, repaglinide, netiglinide, okay, which have action similar to sulfonylureas, but they have a quick onset of action and a short duration of action. So in case of postprandial hyperglycemia, they are the preferred drugs. Then you have biguanides. Okay, metformin is widely used for the treatment of diabetes. So we should all know about metformin. So it's a peripherally acting drug, okay, compared to sulfonylureas or meglitinides, which are secretagogues. You also have thiazolidinediones, okay, rosiglitazone, pioglitazone, which are insulin sensitizers. Okay, how they act? They are basically activators of PPAR, okay, that is peroxisome proliferator activated receptor, okay, which is involved in lipid metabolism. Okay, then you have alpha glucosidase inhibitor. Alpha glucosidase is an enzyme which basically causes breakdown of complex carbohydrates to simple carbohydrates. Okay, so you have inhibitors of this enzyme which are known as alpha glucosidase inhibitors. Okay, example are acarabose and miglitol. Then you have in postprandial hyperglycemia, these are widely used. Okay, then you have glucagon-like peptide, okay, agonist, GLP-1 agonist, okay, which are the newer class of drugs. Okay, so these basically stimulate the release of insulin. Okay, like your excitanide, liraglutide. Okay, so GLP-1 agonist, although they are known as oral hypoglycemic agents, they are not given orally; they are administered subcutaneously. Okay. Then you have the new class of drug, that is DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors. Okay, so these are basically the inhibitors of the enzyme DPP4. Okay, which metabolizes GLP. Okay, so the duration of GLP is prolonged, which then stimulates the release of insulin. Okay, sitagliptin, okay, then vildagliptin. Okay, so they are given orally and therefore widely used. Another new class of drugs is the sodium glucose linked transporter inhibitors. Okay, that is dapagliflozin. Okay, so these are the newer drugs for the treatment of diabetes. Out of that, the conventional drug sulfonylureas. Okay, we should all be familiar how it acts. Okay, so sulfonylureas, it binds to the pancreatic beta cell. In the pancreatic beta cell, there are receptors which are there for sulfonylureas. Okay, so it binds to the potassium ATP channels. Okay, and it causes closure of the potassium ATP channels. As a result, there is membrane depolarization. This causes influx of calcium. There is degranulation of the insulin. Okay, so these, when there is influx of calcium, the synaptic vesicles which contain insulin, they fuse to the presynaptic membrane, and as a result insulin is released. Okay, so what we have to remember is that sulfonylureas are secretogogues. They are basically cause release of insulin from the pancreas. They also have other mechanisms which may not be the primary mechanism, like they potentiate the action of insulin on the target tissues, and they also cause reduction in the serum glucagon. Okay, we know that glucagon antagonizes the action of insulin. Okay, so these are also the mechanisms how sulfonylurea acts. What are the adverse effects of sulfonylureas? Okay, that was the main concern with the use of the first generation sulfonylurea, that is hypoglycemia. Okay, because they had long duration of action like chlorpropamide, okay, tolbutamide, okay, they caused this hypoglycemia. Okay, with the second generation, incidence is much less, but still this is the adverse effects which is seen with this class of drugs. They also cause weight gain. Okay, mild weight gain is also seen with the sulfonylureas. Allergic reactions, right from agranulocytosis, hemolytic anemia, thrombocytopenia. Okay, but these are rare adverse effects. With alcohol, they can also cause disulfiram-like reaction. Okay, there were certain concerns regarding adverse cardiovascular events which were seen with the use of sulfonylureas. Okay. The next class, that is metformin, okay, biguanides, where the drug is metformin. Okay, we should also be familiar with this drug because widely used, okay, for the treatment of diabetes. Okay, how it acts? Sulfonylurea, we saw that it basically causes stimulation of insulin, whereas biguanide is a peripherally acting drug. It inhibits the gluconeogenesis. Okay, gluconeogenesis is what? The formation of glucose from the non-carbohydrate source. Okay, so by activating an enzyme, that is AMPK, AMP activated protein kinase, it inhibits gluconeogenesis. Next mechanism is also by increasing the peripheral utilization of glucose. Okay, so there is more of GLUT4 transporters, and from the periphery, the glucose, it enters the muscles. So the peripheral utilization of glucose is there, and therefore the blood glucose levels it reduces. It also inhibits absorption of glucose from the intestines. Okay, these are some of the mechanisms how metformin, okay, acts. It has a small half-life, okay, short half-life of about 2 hours. Advantage of the metformin over sulfonylureas. Okay, metformin does not cause hypoglycemia. Okay, so hypoglycemia was a major concern with the use of sulfonylureas. Then metformin is said to be cardioprotective. Okay, it's also known to lower the lipid levels. Okay, so most of the diabetic patients also have cardiovascular disorders. Okay, so that's another benefit of metformin, that it is cardioprotective, lipid friendly. Okay, and it does not result in weight gain. Instead, it causes weight loss. Okay, so then sometimes it is exploited because of this property that it can cause weight loss. Okay. Disadvantage of metformin over sulfonylurea. So there are certain adverse effects which are again peculiar to metformin, like metallic taste, nausea, vomiting, okay, generally seen with the initiation of the therapy. Then vitamin B12 deficiency, okay, anemia with long-term use of metformin is seen, okay. Then lactic acidosis, okay, much less with metformin, was much more with fenformin, because of which it was withdrawn. But in those patients who have certain renal comorbidities, we have to monitor, okay, because it can cause lactic acidosis. Indications, okay, so mainly obese patients of type 2 diabetes, okay, because it can cause weight loss. It is a first line drug. It's mainly used either alone or in combination, not only with sulfonylureas, but with the other drugs like DPP-4 inhibitors, okay. In certain conditions like polycystic ovarian syndrome, okay, generally such women, they are obese, okay, and they have hyperinsulinemia, okay, and metformin, we know it can reduce the insulin levels and it can also cause weight loss, okay. Therefore it is useful in case of polycystic ovarian syndrome, okay. Management of diabetes, we generally start with diet, exercise, and we, if the patient has mild diabetes, we ask them to go for dietary and exercise for 6 months. When we again see the blood glucose levels, if it is not controlled, then we start with the drug therapy, okay. Generally monotherapy started in obese individuals, metformin, non-obese sulfonylureas. If there is postprandial hyperglycemia, meglitinides, acrobos are preferred. When there is complications, okay, there is nephropathy, okay, retinopathy, okay, we go for insulin, okay. You can also use insulin in combination with the oral antidiabetic drugs depending upon the response of the patient, okay. So must know questions under this topic. Classify insulin preparations, describe the therapeutic uses, adverse effects of insulin. You can also be asked to classify the oral antidiabetic drugs, describe mechanism ADR of sulfonylureas, and as a short note, okay, on metformin, we should all be aware. Okay. Now the next topic under endocrine, corticosteroids. Okay, so under corticosteroids, first the classification depending upon the duration. Short acting, intermediate acting, long acting. Short acting, you have hydrocortisone, 8 to 12 hours. Intermediate acting, prednisolone, methylprednisolone, 12 to 36 hours. Or long acting, you have dexamethasone, betamethasone. Okay. Uses of corticosteroids, this is very, very important. Okay, so we classify the uses into endocrinal and the non-endocrinal use. Okay, so as a replacement therapy in deficiency state, okay, where there is deficiency of corticosteroids and you want to supplement exogenously. Okay, so which are those conditions? Adrenal insufficiency. Okay, basically because of diminished gland function. Okay, and here it could present as an acute crisis, okay, which is a medical emergency. So hydrocortisone hemisuccinate parenterally, that is indicated. In chronic adrenal insufficiency, orally also corticosteroids can be given. Then third condition is congenital adrenal hyperplasia, where there is deficiency of the enzymes which are required for the synthesis of the steroids. Okay, here hydrocortisone, okay, which is given orally. Then the non-endocrinal uses. Okay, so I will not go into the details, but I'll just talk about the conditions where they are used. Okay, so because these corticosteroids we know have anti-inflammatory properties, so inflammatory conditions like rheumatoid arthritis, osteoarthritis, okay, rheumatic fever, acute gout, okay, when the NSAIDs are not responding, okay, these conditions, the corticosteroids can be used. Okay, the other conditions include allergic reactions. It could be mild, it could be severe, okay, drug-related angioedema, Stevens-Johnson syndrome, okay. Corticosteroids have immunosuppressant and anti-inflammatory properties, okay. So, in allergic reactions, they are indicated. Okay. Septic shock, okay. There also, they can suppress the immune reaction, okay. So, along with the other drugs, steroids are also indicated. Bronchial asthma, if it's a medical emergency like status asthmaticus, okay, hydrocortisone is used. Or in chronic asthma, okay, we can use oral prednisolone. Or in case of persistent and intermittent type of persistent type of asthma, mild, moderate, and severe, the inhalational corticosteroids are mainly used. Intestinal diseases, Crohn's disease, okay, inflammatory bowel disease, again anti-inflammatory property of steroid is exploited. Okay. Cerebral edema, dexamethasone, it has been shown to reduce the edema, so in this condition it is used. Various malignancies, okay, mainly involving the lymphocytes, okay, corticosteroids have lympholytic action. Therefore, in those lymphomas, they are indicated. Organ transplantation, to prevent the graft rejection. Okay, so here again steroids are used. Thyroid storm, okay, again corticosteroids because of its anti-inflammatory immunosuppressant property is used in this condition. Various eye diseases, allergic conjunctivitis, neuritis, anti-inflammatory property. Topically, these corticosteroids can be used. Then for skin infections, right from dermatitis, okay. Then various types of skin diseases, the corticosteroids or either topically or systemically, depending upon the requirement, they can be used. Okay. With the use of corticosteroids, as we saw, so many therapeutic uses of corticosteroids. Okay, but at the same time, there are so many adverse effects also. Okay, so we have to be cautious. Only when indicated, corticosteroids should be used. And there are certain guidelines for the use of steroids. Okay, like tapering the doses. Okay, using short-acting steroids. So these guidelines should always be followed whenever we are using corticosteroids for a long duration. Okay, so what are the adverse effects? Cushing syndrome, okay, like buffalo hump, moon face, height. Then they impair the glucose tolerance, causing hyperglycemia, peptic ulceration. There is susceptibility to infection. So the individual gets immunocompromised, chances of developing TB, okay, all that is much more. Osteoporosis, okay. Then mental disturbances, subscapular cataract, they delay the wound healing, they can suppress the HPA axis. Okay, so abrupt withdrawal should not be there. Okay. These corticosteroids also have some mineralocorticoid action. They can cause sodium and water retention, avascular necrosis of the femur head. That's a peculiar adverse effect of steroids. Okay. Growth retardation in children, in muscle weakness. Steroids, they are also required for the normal functioning of the muscles. Okay, so these are some of the adverse effects. Contraindications, okay, right, depending upon the adverse effects, we can extrapolate. So the contraindications would be like peptic ulceration, hypertension, diabetes, okay, certain infections, bacterial, viral, okay, TB, osteoporosis. Already the patient has osteoporosis, you cannot give steroids, okay, which can further cause osteoporosis, epilepsy and psychosis. Okay, so the must know question under this topic, generally as SAQ or LAQ, on the therapeutic uses and the adverse effects of steroid can be asked. Now the last topic under endocrine, we will quickly finish anti-thyroid agents. Okay, so this is the classification. So the thioamides, propyl thiouracil, methimazole, carbimazole. Okay, so these are the conventional drugs. We also have anionic inhibitors. They use as declined, not used anymore. Iodides, Lugol's iodine, sodium and potassium iodide. We have radioactive iodine, okay, I-131, and certain beta blockers like propranolol, which can inhibit the peripheral conversion of T4 into T3. Okay. So I'll talk about the main class under the antithyroid, that is thioamides. Okay, so what is the pharmacological action? Basically, they are inhibitors of synthesis of T3 and T4. Okay, how they act? They act by inhibiting an enzyme, that is thyroid peroxidase. This enzyme has important functions as far as the synthesis of the T3 and the T4 is concerned. Okay, so it's synthesized in the thyroid follicles. Okay, so this thyroid peroxidase enzyme, okay, it is responsible for the organification, okay, condensation. Okay, so like here it is shown. Okay, so this peroxidase enzyme is required basically for the oxidation as well as the coupling reactions, okay, and iodination, which are important steps in the synthesis of the T3 and the T4. Okay, so this enzyme is inhibited by the thioamides. Okay, as a result, it inhibits the T3 and the T4 synthesis. It also, propyl thiouracil has additional property that it also inhibits the peripheral conversion of T4 into T3. Okay, adverse effects like agranulocytosis, goiter has been seen with the thioamides. Okay. Now this is one SCQ which can come, that is difference between propyl thiouracil and carbimazole. Okay, as you can see, propyl thiouracil less potent compared to carbimazole. It is highly plasma protein bound. It does not cross the placental barrier, because of which it is safe in pregnancy, short duration of action compared to carbimazole, which is longer acting. Okay, multiple doses are required compared to carbimazole, which is given OD. Okay, so longer duration. Okay, it has additional property. It inhibits the peripheral conversion of T4 into T3. Okay, whereas carbimazole does not have this property. Propylthiouracil no active metabolite, whereas carbimazole, okay, it gets converted to methimazole. Okay, and as we discussed, propylthiouracil is safe in pregnancy, whereas carbimazole cannot be given. Okay, it is also not secreted in the milk. Okay, so breastfeeding mothers can also use propylthiouracil. Okay, clinical uses. Okay, so mainly conditions where there is hyperthyroidism. Okay, Graves' disease, which is an autoimmune disorder. Okay, toxic nodular goiter, where surgery is not possible. To reduce the T3, T4 levels, you have to give these drugs. Okay, pre-operatively. Okay, so before the surgery, you want to make the patient euthyroid. Okay, so these drugs can be used. In pregnancy, propylthiouracil drug of choice, along with radioactive iodine. Radioactive iodine, although highly efficacious, it has a very slow onset of action. So in the initial part of therapy, we can use these thioamides. Okay, thyroid storm. Okay, where there is the excessive release of T3 and T4 into the circulation, which can cause cardiac arrhythmias. Okay, so here, out of the various drugs, propylthiouracil is also one of the drugs used for this condition. Next important class is radioactive iodine. I-131 is the isotope of iodine which is used. Mechanism is it emits the beta particles which cause destruction of the follicular cells, and we know that follicular cells are the site where these T3 and T4 are synthesized. So if they are destroyed, then the production of T3 and T4 will go down. Okay. Only disadvantage is that although the action is permanent, it has a slow onset of action. Advantage of radioactive iodine: treatment is simple, convenient. It can be done on an OPD basis, inexpensive, no risk of surgery, scar, and permanently cures hyperthyroidism. Okay. Disadvantages are also there: slow acting, so therefore it is combined with the thioamides. Okay. High incidence of hypothyroidism is also seen. Okay. Although you are giving these drugs, sometimes it can also cause hyperthyroidism. Okay. Not suitable in special subgroups like pregnancy, children, young patients. And although rare, there is a risk of thyroid carcinoma with the use of radioactive iodine. Okay, uses. Okay, so basically the hyperthyroid conditions which we discussed: Graves' disease, toxic nodular goiter, thyroid carcinoma. Okay, radioactive iodine can be used, and it is contraindicated in pregnancy, children, and nursing mothers. Okay, so must know questions under this topic: classify the thyroid inhibitors, explain mechanism of action, ADR uses of anti-thyroid drugs, mainly propylthiouracil. Okay, write advantages and limitations of radioactive iodine therapy, and then differentiate between propylthiouracil and carbimazole. Okay, now moving on to the last system, that is blood, under which only one or two parts I will be covering. Okay, so basically under blood, an important question which can come is difference between heparin and warfarin. Okay, so these are all anticoagulants, but what are the differences between heparin and warfarin? Okay, so heparin is naturally occurring. Okay, it's obtained from a natural source compared to warfarin, which is synthetic in nature. Okay, chemically, if you say, heparin is a mucopolysaccharide compared to warfarin, which is a coumarin derivative. Okay, route of administration for heparin, it is parenterally. Okay, IV, subcutaneous; warfarin, orally. Mechanism of action of these drugs are also different. Heparin basically activates the antithrombin 3, okay, which will further inhibit the anticoagulant factors like factor 10, okay, and 9. Whereas when we talk about warfarin, it inhibits the synthesis of vitamin K dependent clotting factors like factor 2, 7. Okay. Onset of action for heparin is rapid but short duration, whereas warfarin delayed but longer acting. So rigorous monitoring is required with heparin, okay, APTT, and whereas with warfarin, INR and prothrombin time is sufficient. Heparin is safe in pregnancy. That's another advantage of heparin, whereas warfarin is teratogenic. Okay, mainly use heparin for initiating the therapy, and then for maintenance, warfarin can be used. If there is an overdosage of heparin, then protamine sulfate, okay, that's the drug. Whereas for warfarin, vitamin K, okay, that can be given to antagonize the action of warfarin. Another question that can also come is What is the advantage of low molecular weight heparins over conventional heparin? Okay. So when we say low molecular weight heparin, that means from conventional heparin, which is having a higher molecular weight around 10,000. Okay, you convert it into the lower molecular weight heparin of about molecular weight 4 to 7,000. Okay. The lower molecular weight heparins have several advantages over the conventional heparin, okay, like better bioavailability of about 90% compared to heparin, which has around 30%. Longer duration of action, 24 hours. Okay, so one subcutaneous injection will take care compared to heparin, which has a shorter duration. Frequency of administration, okay, for heparin it is about 6 to 8 hours compared to once for low molecular weight heparins. Adverse effects like bleeding, okay, that is much less with the low molecular weight heparin, thrombocytopenia, thrombosis, okay, all this is also less. Lab monitoring, okay, not as rigorous as conventional heparin. Okay, so low molecular weight heparin used for venous thromboembolism, pulmonary embolism, okay, basically for its anticoagulant property in unstable angina. Also during dialysis to maintain the patency of the tubes, it can be used. So the must-know question under this topic: differentiate between heparin and warfarin. Write the advantages of low molecular weight heparin over conventional heparin. Okay, so we stop here. Okay, so we have covered the must-know questions. Okay, and the important parts under the cardiovascular, the endocrine, and blood. Thank you so much.
Thank you very much, madam, for your most informative lecture. I definitely feel that the students will be benefited by this.
Thank you.
Right.
Thank you.
Now I call upon the next speaker, that is Dr. Nazir madam from M.A. Rangunwala Dental College, Pune. Nazir madam, I welcome you here for the next session, next lecture. Please, you can start.
Yes, sir. Am I audible, sir?
Yes, ma'am.
Yes, yes.
Okay.
Yes, ma'am.
I'm Dr. Nazima. A very good afternoon to all of you. Today, I shall be discussing in brief antimicrobial agents and orthocoids. Okay, we shall start with antimicrobial agents and move ahead. First, we'll start with sulfonamides. Now, sulfonamides, which are classified as short-acting, intermediate, long-acting, and those for special purpose. Under short-acting, we have drugs like sulfadiazine, intermediate-acting sulfamethoxazole, long-acting sulfadoxine, sulfamethopyrazine, and those for special purpose, that is sulfacetamide sodium, sulfasalazine, and silver sulfadiazine. Now, these drugs were the initial drugs to be used clinically. As such, singly, these drugs are hardly used nowadays except those for special purposes, that is drugs like sulfacetamide sodium, which are used in ocular conditions, sulfasalazine used in GI autoimmune conditions, and silver sulfadiazine, which is used topically in burns patients. Then we come to cotrimoxazole, which is a combination of trimethoprim plus sulfamethoxazole. Now, this drug, which is a fixed drug combination of trimethoprim and sulfamethoxazole in the ratio of 1:5. Now, this combination is a sidal combination, that is, the organisms are killed by this combination, whereas sulfonamides are having a bacteriostatic action, that is, they will just suppress the growth of the microorganisms. The microorganisms will not be killed, but the growth will only be suppressed with these drugs. Now, coming to the mechanism of action. Now, this drug mechanism of action is very important. It can be asked as a short note. Now, the conversion of PABA, para-amino benzoic acid, to dihydrofolic acid, which takes place by the enzyme folate synthetase. Now, this enzyme folate synthetase is inhibited by the sulfonamide, whereas the conversion of dihydrofolic acid to tetrahydrofolic acid takes place with the help of enzyme dihydrofolate reductase. Now, this takes place with the help of trimethoprim. Now, trimethoprim inhibits the conversion of DHFA to THFA, that is folic acid, which is not formed. So ultimately, the organisms will be killed. So this drug cotrimoxazole acts by sequential blockade. Mechanism of this drug is very important. It can be asked as a short note. Sulfonamides, as such, these are not asked. Now coming to the uses of cotrimoxazole. These drugs are used in orodental infections. Apart from orodental infections, these drugs are used in urinary tract infections, bacterial diarrheas and dysenteries, and in AIDS patients to treat pneumonia by pneumocystis jirovecii. So these are the uses of cotrimoxazole. But the use of this drug has declined as such because of resistance. Unless a sensitivity test is done and if the organisms are sensitive, then in such cases we are using this drug cotrimoxazole. Then we come to the other group of drugs, which are the fluoroquinolones. Now, fluoroquinolones, they are classified into first generation and second generation drugs. First generation drugs are the older drugs like norfloxacin, then we have ciprofloxacin, we have ofloxacin, and pfloxacin. The second generation drugs, which are the newer drugs, they are classified into levofloxacin, then we have lomifloxacin, sparfloxacin, moxifloxacin, gemifloxacin, prulifloxacin. Now this topic, fluoroquinolones as such, is a important topic. You can be asked a full question on this topic about the classification, the mechanism of action, and the uses as well as the adverse effects of these group of drugs. Now coming to the mechanism of action of the fluoroquinolones, they act by inhibiting the bacterial DNA gyrase. So that is how this enzyme which is inhibited, and thus the drugs are bactericidal in nature. Now we come to ciprofloxacin, which is the prototype drug. Ciproflox in this group of drugs is the prototype drug. It mainly acts on the gram-negative bacilli. The adverse effects of ciproflox, it causes tendinitis, tendon rupture. So the side effects, again, this drug is not used in pregnancy because of the teratogenic effects. Coming to the uses of this drug, ciproflox, it is used in orodental infections, but of course in orodental infections, instead of ciproflox, we prefer oflox and moxifloxacin, which are more effective on the organisms which are present in the oral cavity as such. Again, these drugs are useful in other infections like skin, soft tissue infections, wound, gynecological infections, and skeletal infections. So these are the multiple uses of the fluoroquinolones as such. The newer drugs, that is the second generation fluoroquinolones like sparfloxacin. Now, sparflox or the second generation mainly have activity on the gram-positive organisms. So they are effective on the gram-positive organisms as compared to ciproflox. However, there is adverse effect related to this drug, that is this drug causes QT prolongation, which may lead to arrhythmia. So again, this side effect has to be kept in mind when using this drug. Now we come to the other group of drugs, which are the nitroimidazoles. Now in this topic, we have metronidazole, which is the prototype drug. Now again, this drug metronidazole is an important drug. Short note can be asked. on this topic as such. This drug is the prototype drug in the Nitroimidazoles. The half-life, the plasma half-life of this drug is about 8 hours, so it can be given thrice a day. Now, coming to the adverse effects of this drug, metronidazole, it leaves a metallic taste. Once the drug is taken, it leaves a bad metallic taste in the mouth for a certain time, which is not comfortable to the patient as such. Then it also has drug interactions, like it causes disulfiram like intolerance to alcohol. So the patient has to be asked not to consume alcohol after taking this drug. Then coming to the uses of metronidazole. Metronidazole as such is frequently used in orodental infections, especially in ANUG or acute necrotizing ulcerative gingivitis. The dosage of which is 200 to 400 milligrams thrice a day, that is TDS, for a minimum period of 5 days. So that is the dosage which we generally use when we use this drug in case of orodental infections. But generally this drug is not used alone. It is combined with other drugs which have activity on the other organisms as such. It is also used in periodontitis. So these are the uses of this drug in orodental infections. The other bacterial infections where this drug can be used is in case of antibiotic associated pseudomembranous enterocolitis due to Clostridium difficile. So this is another infection where this drug is quite helpful. It is the drug of choice over here. Again, this drug metronidazole is the drug which is quite helpful in peptic ulcer due to H. pylori. It is one of the components of the triple drug therapy in case of H. pylori infection causing peptic ulcer. The other uses related to metronidazole, it is used in protozoal infections. Now here in protozoal infections, this is the drug of choice. It is the first drug of choice in case of protozoal infections, that is in case of intestinal amoebiasis, then in case of intestinal giardiasis, and in trichomonas vaginitis. So these are the multiple uses of metronidazole. Then there are the other drugs in this group, which are, for example, tinidazole, we have secnidazole, ornidazole, and cetranidazole. So these drugs, the advantage of these drugs is the longer half-life. So therefore, these drugs are preferred rather than metronidazole nowadays. Okay? So indications of these drugs are similar to that of metronidazole. Now coming to the beta-lactam antibiotics. Now beta-lactam antibiotics, they are classified into penicillins and cephalosporins. Now they are so called because they have a beta-lactam ring. So this is the hallmark of these beta-lactam antibiotics. So initial drugs are the penicillins and the cephalosporins. The later additions are the monobactams and the carbapenems. So these are the later additions in this group. Now coming to the penicillins, which are the very important drugs nowadays which are being used. The mechanism of action, which is again important, this topic penicillins can be asked as a full question. So the mechanism of action, again in beta-lactam antibiotics, the mechanism, then the questions, the uses of penicillins, the adverse effects. So this can be asked as a full question in this topic. Now penicillin G. This drug, the other name for penicillin G is benzyl penicillin. Now this drug is having a narrow spectrum. It especially acts on the gram-positive organisms. So the spectrum is narrow as such. There could be bacterial resistance because of the release of enzyme penicillinase by the bacteria, which may inactivate this drug as such. Again, the another limitation of this drug is it is acid labile in nature, so it cannot be given orally. It has to be given parenterally. Now, the adverse effects again are important of this drug. Hypersensitivity reactions with this drug, which are a major problem why this drug is not preferred nowadays. So better drugs which are available now, this hypersensitivity reactions which are rare, but then it is you can say life threatening, and therefore this drug penicillin G, nowadays the use of penicillin G has declined because of this problem of hypersensitivity. Coming to the uses, it can be used in dentistry for the treatment of acute necrotizing ulcerative gingivitis. However, this drug, because other drugs are there, this drug is penicillin G, which is not preferred for this condition. General medical uses are there. It is specially used in gram-positive infections, that is streptococcal, pneumococcal, then the meningococcal infections. Of course, in STDs like gonorrhea, syphilis, this drug is quite useful. The other infections where this drug can be used are in case of diphtheria, tetanus, and the rare infections like gas gangrene and anthrax. There are the other prophylactic uses of penicillin G, that is the prevention of rheumatic fever. This drug is very helpful, especially benzathine. Penicillin is the drug of choice in case of rheumatic fever. Again, surgical prophylaxis, this drug can be used for surgical prophylaxis to prevent infections in the surgical wound. When in agranulocytosis patients, this drug penicillin G will prevent the infection. So these are the prophylactic uses of penicillin G, again, which can be asked in the full question, that write a note or add a note on the prophylactic uses of penicillin G. Now coming to the semi-synthetic penicillins. After penicillin G, we have the semi-synthetic penicillins which have come up later. Now these are classified into acid-resistant penicillins, that is phenoxymethyl penicillin, which is also called penicillin V. Now this drug can be given orally, that is the advantage of this penicillin V. Then we come to the penicillin is resistant penicillins like methicillin, cloxacillin, dicloxacillin. Now these drugs, they are generally given in infections where the organisms are producing this enzyme penicillinase. And then we come to the extended spectrum penicillins. Now these drugs are classified into aminopenicillins like ampicillin, bacampicillin, amoxicillin. Then there are the carboxy penicillins like carbenicillin, and we also have the uridopenicillins like piperacillin, mesdocillin. Now, amongst all these drugs, the aminopenicillins are the most commonly used drugs in case of orodental infections. Now, aminopenicillins, ampicillin is belonging to the aminopenicillins. Coming to the uses of this drug, it is a broad spectrum drug, that is, it is used in multiple infections, it acts on a large group of organisms. Therefore, it is broad spectrum in nature. Now here, either ampicillin or amoxicillin, which is combined with metronidazole to treat acute necrotizing ulcerative gingivitis. So in dentistry, generally we are combining metronidazole with ampicillin or amoxicillin to treat this condition. So these are the uses in dentistry as such. Apart from the dental uses, there are the other medical uses. Many medical uses are there of this drug. This drug is effective in urinary tract infections. Then in case of respiratory tract infections, meningitis, gonorrhea, bacillary dysentery, typhoid fever. Also in cholecystitis, subacute bacterial endocarditis, septicemias, S. pylori. So as you can see, multiple uses are there for this drug, but then we are not preferring this drug nowadays because of the resistance and because better drugs are available. So only where the organisms are sensitive, in such cases, ampicillin is preferred. Adverse effects, it causes diarrhea, which is a very common side effect related to ampicillin. Now, bacampicillin, which is a prodrug, it is converted to ampicillin and then the drug acts. Then we come to amoxicillin. Now, amoxicillin, which is similar, the indications of course are quite similar to ampicillin. However, as compared to ampicillin, it has got a better oral absorption and there are less chances of diarrhea with this drug as compared to ampicillin. Again, the frequency of administration of this drug is less as compared to ampicillin. Now, coming to the uses, this drug amoxicillin, which is used in orodental infections in the dosage of 250 to 500 milligrams thrice a day for a minimum period of 5 days. So the frequency with amoxicillin is thrice a day, whereas for AMPI, we have to give it 4 times a day or QID. So that is again another difference why we are not preferring ampicillin. Now coming to the other drugs in this class, we have the other drugs which are carboxypenicillins like carbenicillin and the uridopenicillins like piperacillin, mesdocillin. These are the anti-pseudomonal penicillins. So in case the infection is having pseudomonas group of organisms, then these drugs are preferred as such. Now coming to the beta-lactamase inhibitors. Now beta-lactamase are a group of enzymes which are released by the gram-positive as well as the gram-negative organisms, and these enzymes, they open up the beta-lactam ring and thus inactivate the beta-lactam antibiotic. So in certain infections where the organisms are releasing beta-lactamase, in such cases beta-lactamase inhibitors like clavulanic acid, sulbactam, tazobactam, these are the drugs which are needed to be combined with the other drugs so that the so that the antibiotic is effective against those infections. Now, clavulanic acid, this drug is called a progressive inhibitor. That is, the inhibition increases with time. Initially, it is the later. Initially, it is reversible. Later, it becomes irreversible. So that is again, it is also called a suicide inhibitor. Coming to the uses of this drug, clavulanic acid. Clavulanic acid generally is combined with amoxicillin, the combination which is called as co-amoxiclav. Combination of clavulanic acid combined with amoxicillin, which is called as co-amoxiclav. Now, this combination is frequently used in a variety of conditions. So, uses are multiple. It is used in large number of infections like skin infections, soft tissue, urinary, biliary, and respiratory tract infections. Also, intra-abdominal, gynecological, and also in orodental infections, gonorrhea. So, the uses of this combination are multiple, and of course, this drug is the drug which is quite frequently used nowadays. Then in the same group, that is the beta-lactamase inhibitors, we have drugs like sulbactam, we have tazobactam. Now these drugs are used parenterally, whereas clavulanic acid is used orally. Now these drugs, they, for example, sulbactam, which is combined with ampicillin, whereas tazobactam, which is combined with piperacillin. So these are generally used in the hospital settings because they have to be given parenterally, and it may be cumbersome to give these drugs when a patient is at home, when a person is at home. So these are generally used in the hospital settings. Now coming to the other group of drugs, which are the cephalosporins. Now cephalosporins again belong to the beta-lactam antibiotics because they the nucleus which consists of a beta-lactam ring, it is called the 7-aminocephalosporanic acid, the nucleus which is called the 7-aminocephalosporanic acid. Now these drugs, they are classified into 4 generations. The first generation again classified into parenteral and oral. Parenteral drugs like cefazolin, whereas oral drugs we have cephalexin, we have cephadroxil. Then there are the second generation drugs. Parenteral we have cefuroxime, oral we have cefaclor, we have cefuroxime acetyl, and cefprozil. Then there are the third generation cephalosporins, like again third generation, which is classified into parenteral and oral. In the parenteral ones, we have cefotaxime, we have ceftizioxime, ceftriaxone, ceftazidime, cefoperazone. So these are the drugs which are given parenterally, whereas the oral third generation drugs, we have cefixime, we have cefpodoxime, ploxetil, we have cefdinir, we have ceftibutane. So these are the third generation cephalosporins. In the fourth generation cephalosporins, we have only the parental drugs, which are cefepime and cefpyrone. So these are the four generations of the cephalosporins. Now these drugs as such are having a bactericidal action, that is, the organisms are killed with these drugs. They also have the mechanism of action of these drugs, cephalosporins, is similar to that of penicillins. That is, they act by inhibiting the bacterial cell wall synthesis. Of course, there could be resistance to these drugs by the organisms who, when they release beta lactamases, which are in this case called the cephalosporinases. So cephalosporinases, if they are released by the bacteria, then there could be resistance to these drugs. Now, the different generations, the first generation, the spectrum differs with each generation. The first generation ones especially are more effective on the gram-positive organisms. So, drugs like cefazolin, cephalexin, cefadoxil act mainly on the gram-positive organisms. Cefazolin, which is used for surgical prophylaxis, whereas cephalexin, which is oral drug, it is used as an alternative to amoxicillin. Cefadoxil commonly is used in dental infections as such. Coming to the second generation cephalosporins, the second generation are more effective on the gram-negative organisms and also on the anaerobic organisms. So that is the spectrum of the second generation cephalosporins. Now, cefuroxime, which is the parenteral drug given parenterally, whereas cefuroxime acetyl, which is an oral drug which is given in dental infections, which is preferred in dental infections. So that is these are the uses of the second generation drugs. Then coming to the third generation cephalosporins. The third generation, there are many drugs, parental as well as the oral ones. They mainly act on the gram-negative organisms and also on the Pseudomonas group of organisms. Now these third generation cephalosporins are less suitable for dental infections as such. They are not used in or less suitable for dental infections. Therefore, at least, but you should be knowing about these drugs. Cefotaxime, which is the prototype drug in the third generation. The use of this drug is in case of serious life-threatening infections, where the patient, especially in the hospital settings, because again this drug is given parenterally. Okay, so parenterally it is life-saving drug. Then we have ceftriaxone. Again, the advantage of ceftriaxone is the longer duration of action with this drug. It can be given once or twice daily. So this is the advantage of ceftriaxone. Again, another advantage of ceftriaxone is that it penetrates the CSF, so it can be used in meningitis patients. So that is the advantage with ceftriaxone. The use of ceftriaxone is in serious life-threatening infections like bacterial meningitis, then in case of typhoid fever, but here it is used in case of multi-resistant typhoid fever. Otherwise, ciproflox is the drug of choice, but if the infection is resistant, then you can go in for ceftriaxone. Then the other uses are in case of abdominal sepsis and septicemias, again, which are serious infections. So this drug is a life-saving drug as such. Coming to the adverse effects, this drug ceftriaxone causes hypoprothrombemia and bleeding. So these are the side effects with ceftriaxone as such. Coming to cefoperazone, now this drug cephalosporin, it has disulfiram-like reaction with alcohol, and therefore the patient should be advised not to consume alcohol after taking this drug, cephalosporin. Then coming to cefixime, which is an oral drug. Now this drug is a long-acting drug. The dosage of this drug is 200 to 400 milligrams BD or twice a day, and it is used in multiple infections like respiratory tract infections, urinary tract infections, and biliary tract infections. So uses are multiple with this drug. With side effect, it causes diarrhea, which is very common with cefixime. Then coming to cefpodoxime proxetil. Now this drug is a prodrug, which is converted to cefpodoxime to become active. Then we come to the fourth generation cephalosporins. Now fourth generation cephalosporins, the spectrum is similar to that of the third generation cephalosporins. However, these drugs are resistant to the enzymes which are released by the bacteria, the beta lactamases which are released by the bacteria, and therefore these drugs are used in serious and resistant hospital acquired infections. So these are the reserved drugs as such, which are used in serious infections as such. Coming to the adverse effects of cephalosporins as such, the there is pain on intramuscular injection with certain drugs. There could be thrombophlebitis on intravenous injection. Diarrhea is common with certain drugs. There could be hypersensitivity again. Certain drugs, sometimes there could be hypersensitivity reactions also with these drugs. Again, some of the drugs are having a nephrotoxic potential, and there could be bleeding again with certain drugs like cefoperazone and ceftriaxone. So these are the side effects which are related to the cephalosporins. Now coming to the uses of these drugs, uses of cephalosporins. Now dental infections, these drugs are used as alternatives to penicillin or amoxicillin. So they can be used as alternatives to penicillin or amoxicillin, and also in penicillin or amoxicillin resistant infection. So where the patient is resistant or where the patient is allergic, in such cases, these drugs can be used. Now here in dental infections, we are generally preferring the oral first or second generation cephalosporins, because they are more effective on the organisms which are present in the oral cavity. Then the other general medical uses, which are again many, these drugs are used as alternatives to penicillin where the patient may be allergic to penicillin. So in such cases, cephalosporins may be the drugs of choice. In the other infections, respiratory tract infections, urinary tract infections, soft tissue infections, then the infections where the organisms like staphylococci, which are releasing the enzyme penicillinase. So in such cases, uh, these drugs are quite helpful. Then in serious infections like septicemia, surgical prophylaxis, meningitis, STDs like gonorrhea, typhoid, mixed aerobic, anaerobic infections, and also in serious hospital acquired infections. So these are the multiple uses of these drugs where these drugs can be used. So that is about the cephalosporins. Now coming to the monobactams, again, which are included under the beta-lactam antibiotics. Now these drugs are so called the monobactams because they have only one ring, the other ring is missing. So the beta-lactam ring is there, the other ring which is missing. For example, us threonum, which lacks cross sensitivity with the other beta-lactam antibiotics. So these drugs are preferred when the patient is allergic to penicillins or cephalosporins. So in such cases, these monobactams are preferred. because there is no specific indication of monobactams in dentistry. So these drugs are hardly used in dentistry. Then coming to the carbapenems, which are also included under the beta-lactam antibiotics. Now, these again have a beta-lactam ring and therefore they are included in the beta-lactam antibiotics. Examples like imipenem. Now this imipenem, which is having a broad spectrum nature, it acts on a large group of organisms. However, the limitation of this drug is that it is rapidly hydrolyzed by the enzyme dehydropeptidase 1, and therefore the combination of imipenem and cilastatin, which is available, which will inhibit the hydrolysis of dehydropeptidase 1. So imipenem cilastatin combination, which is used in serious hospital acquired infections. Now, the other drugs in this group are meropenem, carbapenem, and doripenem. These drugs, all these drugs are used as reserve drugs when the other drugs cannot be used for some other reason. So that's it about the beta-lactam antibiotics. Now we come to the other group of drugs, which are the tetracyclines, chloramphenicol, and the aminoglycoside antibiotics. Now, tetracyclines and chloramphenicol are included under the broad spectrum antibiotics because they act on a large group of organisms, and therefore the name broad spectrum. Okay, so they are included under the broad spectrum antibiotics. Now, first we'll see the tetracyclines. Now, the tetracyclines have a nucleus of 4 cyclic rings. This nucleus, which consists of 4 cyclic rings, therefore the name tetracyclines. Now, the various drugs which are classified under the tetracyclines are tetracycline, then we have oxytetracycline, then we have demiclocycline, we have doxycycline, we have minocycline. So all these are classified under the tetracyclines group of antibiotics. Coming to the mechanism of action of these drugs are having a bacteriostatic action, and they act by inhibiting the bacterial protein synthesis by binding to the 30S ribosomal subunit. So that is how these drugs are acting. Coming to the adverse effects. Now, adverse effects of these drugs, tetracycline, they are dose dependent. If the dose increases, they could cause damage to the liver. There could be kidney damage. Now, there is an entity which is called as Fanconi syndrome, which occurs with the use of outdated tetracycline tablets. So, the use of expired tetracycline tablets should be avoided. Then phototoxicity again, which is a side effect related to the tetracyclines, which could occur with certain drugs like demiclocycline, doxycycline. So the person should be asked not to go out into the sun after taking these drugs. Then these drugs are having chelating property, and therefore they have side effects on the bones and the teeth. These chelate, which is formed, gets deposited in the bones and the teeth. Now, if taken in pregnancy, lactation, and children, these drugs, these tetracyclines, the chelate will get deposited in the teeth. The teeth become yellow in color, orange in color, and these are ill-formed teeth which are easily susceptible to caries. Then on the bones, chelate, these chelates will get deposited and will inhibit the growth of the children. So again, in children, of course, this side effect is there. Then these drugs also cause super infection. So again, these drugs should be used for a short period, and once the infection is treated, these drugs should be stopped immediately. Otherwise, chances of super infection are quite high with these drugs as such. Contraindications, these drugs, that is the tetracyclines, they are contraindicated in pregnancy, lactation, and children. Uses, they could be used, they are used in orodental infections. Of course, we prefer doxycycline in orodental infections The general medical uses of these drugs are in case of venereal diseases like lymphogranuloma venerum, granuloma inguinal, and also in case of rickettsial infections like typhus. So these are the major indications of these tetracyclines as such. The other uses, these drugs are used as adjuvants in case of amoebiasis as well as in malaria, but this drug is used in case of chloroquine resistant malaria. Also, this is the drug which is used in acne. So these are the uses of the tetracyclines as such. Tetracyclines, generally full question will not be asked, short note could be asked on tetracyclines about the side effects. Side effects are more important, that is the effects of tetracyclines on the teeth, which is more important for you all. Now coming to chloramphenicol. Chloramphenicol, this drug is again classified under the broad spectrum antibiotics because it acts on a large group of organisms. So this drug comes under the broad spectrum antibiotics. Mechanism is again similar to the tetracyclines. It acts by inhibiting the bacterial protein synthesis by binding to the 50S ribosomal subunit. It is having a bacteriostatic action just like tetracyclines. However, it mainly acts on the Salmonella group of organisms. So the activity is mainly on the Salmonella group of organisms. Adverse effects are very important. They are the major side effects. It causes bone marrow depression, which is a serious side effect related to chloramphenicol. Why this drug is not preferred nowadays, it could cause a plastic anemia, a granulocytosis, thrombocytopenia, or pancytopenia. So this is a serious side effect related to this drug. Again, it could cause it causes gray baby syndrome when given to premature infants. So it was earlier given in premature infants, which caused the death of the baby. So these drugs are again not preferred in premature infants nowadays. Uses of chloramphenicol, these drugs are hardly used in dentistry nowadays. Of course, earlier it was used in typhoid fever, but nowadays again better drugs which are available with lesser side effects. So this drug again is not preferred in case of typhoid fever. Topically, of course, this drug is used in ocular conditions like conjunctivitis and also in conditions like otitis externa. So these are the uses of this drug chloramphenicol. Now coming to the aminoglycoside antibiotics. Now these drugs are seldom used in dentistry. The common properties, uh, they are not used or seldom used in dentistry, but of course you should be knowing about these drugs. We'll go through these drugs very fast. Common properties could be asked for you all. They are available as sulfate salts. These drugs, you could be asked about the side effects related to these drugs and the common properties which are related to these drugs. So these drugs are available as sulfate salts. They do not penetrate the brain or the CSF. They are having a bactericidal action, and they act on the gram-negative bacilli. They interfere with the bacterial protein synthesis, and they have got a narrow margin of safety. And also they are ototoxic as well as nephrotoxic. So this, because of these side effects again which are related to these drugs are hardly preferred nowadays. They are classified into systemic aminoglycosides and topical aminoglycosides. Systemic aminoglycosides, we have streptomycin, gentamicin, kanamycin, tobramycin, amikacin, cysomycin, and netilmycin. Topical aminoglycosides, we have neomycin and pramycetin. Now, these drugs, topical aminoglycosides, are too toxic to be used systemically, and therefore they are not used systemically. Now, these drugs, as we have seen, they act by inhibiting the bacterial protein synthesis. They are having a cidal action. They have shared toxicities, that is, the toxicities are similar to all the drugs in this group. That is, they have got a ototoxic potential, nephrotoxic potential, and they cause neuromuscular blockage. Toxicity is very important with these drugs, and of course, these drugs should not be combined with the other ototoxic as well as nephrotoxic drugs. Again, this has to be kept in mind, and therefore you should be knowing about the toxicity part of these drugs. Now coming to the macrolide antibiotics. So macrolide antibiotics, we have erythromycin, which is the prototype drug over here. There are certain limitations of erythromycin. That is, they have a narrow spectrum. They cause gastric irritation. They gastric acid lability is there with this drug. Therefore, these drugs are used as enteric coated tablets. Then less of bioavailability is there with these drugs, and they have a short half-life. Now, these limitations, to overcome these limitations, the newer drugs have been developed, that is the semi-synthetic macrolides like roxithromycin, clarithromycin, and azithromycin. So these are the newer drugs which overcome the limitations of erythromycin. Now, erythromycin is having a bacteriostatic action at low concentrations, whereas there is a cidal action at high concentrations. It also acts by inhibiting the bacterial protein synthesis, and again, it is having a narrow spectrum, mainly acting on the gram-positive organisms, and it is also an enzyme inhibitor. These are some of the features of erythromycin. Uses, coming to the uses of erythromycin, it is preferred in dental infections where the patients may be allergic to penicillins, or in case of penicillin resistant infections. In such cases, this erythromycin is generally used in dental infections, orodental infections. It is also used prophylactically as an alternative to penicillins. So again, prophylactic uses also are there in dentistry with this drug. General medical uses are there of this drug. This drug is used as a substitute to the penicillin. So wherever the organisms are sensitive to penicillins, in such cases, you can use erythromycin. Coming to roxithromycin, this is long-acting drug. Indications are similar to that of erythromycin. Clarithromycin, coming to the uses of this drug, clarithromycin, it is used in respiratory tract infections, orodental infections. It is used as one of the drugs in the triple drug regimen uh, for the treatment of H. pylori, for the treatment of peptic ulcer due to H. pylori. In AIDS patients due to Mycobacterium avium complex. So again, in AIDS patients, this Mycobacterium avium complex, this is the drug of choice. It is one of the drugs in the combination therapy. Again, it is useful in atypical mycobacterial diseases as well as in leprosy. It is the second line drug, erythromycin. Now coming to azithromycin, this drug is having a longer half-life and can be used as a once a day daily dosing. So that is the most important advantage of azithromycin. The uses of azithromycin, it is used in orodental infections and the other indications which are similar to erythromycin. The dosage of azithromycin is 500 milligram OD for a period of 5 days. Side effects are mild GI upset, dizziness, headache. So these are the features of azithromycin. Now coming to the anti-tubercular drugs. Now anti-tubercular drugs are classified into first-line drugs and second-line drugs. First-line drugs are having more efficacy and less toxicity. They are used routinely. Under the first-line drugs, we have isoniazid, we have rifampicin, pyrazinamide, ethambutol, and streptomycin. Then there are the second-line drugs which have less efficacy, more toxicity, or both, and they are used in special circumstances only. Now, under the second-line drugs, we have fluoroquinolones like ofloxacin, levofloxacin, moxifloxacin, ciprofloxacin. Then there are the other oral drugs like ethinomide, we have cycloserine, para-aminosalicylic acid or PAS, and rifabutin. Then there are the injectable drugs like kanamycin, amikacin, capreomycin. Now there is another classification by WHO in 2010 and the revised National Tuberculosis Control Program (RNTCP). It is the DOTS plus guidelines which have alternative grouping of the anti-tubercular drugs, where the anti-tubercular drugs are classified into 5 groups. But we will not go into details of this classification, which is almost similar, but then they are classified into 5 group of drugs. Now coming to the first line anti-tubercular drugs. Now a full question can be asked on the anti-tubercular drugs, the first line drugs especially, and the toxicity. And the toxicity part is very important, as well as the classification of the first line as well as the other drugs, second line drugs. Now coming to the important features, again, any one drug can be asked. The important features of any one of the drugs can be asked. Isoniazid, or H in short, which is having a bactericidal action. It is a cheap drug. Mechanism of action, it acts by inhibition of the synthesis of mycolic acids, which is one of the important constituents of the mycobacterial cell walls. So that is how this drug acts, isoniazid. It is used orally, and there is a genetic variation in the acetylation status of INH. There are fast and slow acetylators, Indians which are generally slow acetylators, and peripheral neuritis, which is a side effect which is more common in slow acetylators. Now this peripheral neuritis, which can be prevented by giving pyridoxine prophylactically 10 milligrams per day. So that is how peripheral neuritis can be prevented. Because hepatitis, this drug is toxic to the liver. So again, this is a side effect related to isoniazid or isonicotinic acid hydrazide. Then the other important drug, first line drug, which is rifampicin or rifampin. Now this again is having a bactericidal action. It acts by inhibiting the DNA-dependent RNA synthesis. It is a microsomal enzyme inducer. Again, side effects which are related to rifampicin or hepatitis, and this drug also causes the urine and the other secretions to become orange red in color. Of course, this is a harmless side effect, but it has to be told to the patient in the beginning. So these are the side effects related to rifampicin. The other uses of rifampicin are in case of leprosy as a second line drug and in the prophylaxis of meningitis. These are the uses of rifampicin. Coming to pyrazinamide. Now, pyrazinamide again is having a bactericidal action. Now, when this drug is added to the regimen, the duration of treatment is reduced, as well as the risk of relapse again is reduced. So, therefore, this drug is included in the therapy for tuberculosis. Now, coming to the mechanism of action of pyrazinamide, it is similar to INH. Again, this drug causes hepatotoxicity, which is a major side effect related to pyrazinamide. Then we have ethambutol, which is having a bacteriostatic action, again, which is included in the first line drugs. The main side effect of ethambutol is optic neuritis. So this side effect is again should be kept at the back of the mind, and the patients um, should be asked about the condition of the ocular about vision. Now coming to streptomycin, now this drug is having a cidal action. Streptomycin, which is again bactericidal, it is used as a reserve drug. So it may not be included in the initial therapy for tuberculosis. So tuberculosis, which has the initial therapy as well as the continuation therapy. So in the initial therapy where all the first line drugs are generally used, so streptomycin may or may not be included in the initial therapy for streptomycin. Now coming to the treatment of oral candidiasis. Now you can be asked about a short note on the treatment for oral candidiasis. Now here the treatment is mainly topical. You use topical drugs. We use topical drugs like clotrimazole and nystatin. So clotrimazole, which is used topically, a 10 milligram crochet of clotrimazole, which is kept in the oral cavity. It is supposed to be dissolved or sucked in the oral cavity, which is used 3 to 4 times a day. Again, another drug which can be used for oral candidiasis is nystatin, where 1 lakh unit tablet, which is kept in the oral cavity, which is allowed to dissolve slowly in the oral cavity, again 3 to 4 times a day. So this is the oral treatment for oral candidiasis. Now, in case the treatment, the infection does not subside with this topical treatment, we generally use systemic therapy with fluconazole, which is given orally in the dosage of 150 milligrams per day for a period of 2 weeks. So here fluconazole is generally given to patients who are not responding to the topical treatment as such. So that's it about the treatment of oral candidiasis. Now coming to the malaria treatment of uncomplicated malaria. Now here generally earlier we were using chloroquine for this regimen, that is 600 milligrams of chloroquine was given stat once the diagnosis of malaria was done, and then it was followed by 300 milligrams which was given on the same day after 8 hours, and then for the next 2 days 300 milligrams which was given. But nowadays, of course, this was combined with primaquine 50 milligrams daily for a period of 14 days. This was the therapy which was given earlier, but nowadays because of the chloroquine resistance which has been developed, the other drugs like artemisinin based combination therapy which is given, which includes artesunate 100 milligrams BD, that is twice a day for a period of 3 days, which is combined with sulfadoxine 1500 milligrams plus pyrimethamine 75 milligrams as a single dose. So this combination which is used nowadays in case of chloroquine resistant malaria. Then we come to this drug, which is metronidazole, which we have already seen. The uses of metronidazole, it is a first-line drug in case of amoebiasis, in case of trichomonas vaginatis, giardia lamblia, and in case of anaerobic infection. So that's it about the antimicrobial drugs. Now we'll see the autocoids. Now in the autocoids, the H1 antagonist or the conventional antihistaminics, which they are also called. That part is important in the autocoid. So we'll go through fast. We'll see in brief about the H1 antagonist. Now on this topic, you can get a full question on the classification of H1 antagonist as well as the uses and especially the uses which are more important, and of course the side effects. So coming to the actions of the H1 antagonists, which are also called the conventional antihistaminics. Now these drugs, the actions of these drugs, they antagonize histamine. Now histamine, which causes bronchoconstriction, and it also causes the tribal response, which includes the wheal, flare, and itch, and it also leads to a fall in blood pressure. So all these are antagonized by the antihistaminic, the H1 antagonist or the conventional antihistaminics. Then these drugs also have an anti-allergic action. These drugs, they suppress the immediate hypersensitivity reactions or the type 1 reactions. They control the urticaria, itching, and the angioedema, which are the symptoms in this type 1 reactions, which occur in the type 1 reactions. So that is about the anti-allergic action. Now on the CNS, these drugs, especially the older antihistaminics, they cause CNS depression because they pass the cerebrospinal fluid, enter the brain and cause CNS depression, whereas the second generation antihistaminics, they do not do not penetrate the brain, and therefore they are non-sedating as such. Now these drugs, the antihistaminics, they also have an anticholinergic action. Now, based on the anticholinergic action, they are classified into those with high anticholinergic action, like drugs like promethazine, we have diphenhydramine, we have dimenhydrinate, we have pheniramine. Then those with low anticholinergic action, drugs like chlorpheniramine, we have hydroxyzine, we have triprolidine, cyproheptadine, and then there are the drugs with minimal or absent anticholinergic actions. These are generally the second generation ones, the newer drugs with absent anticholinergic action. Drugs like fixofenadine, we have estimizole, loratadine, cetirizine, mesolastine. So these are this is the classification based on the anticholinergic action of the antihistaminic drugs. Now coming to the classification of the H1 antihistaminics, again, it is very important. They are classified based, they are classified uh, they are classified as old generation or the first generation and the second generation antihistaminics. Now, again, based on the sedative action, they're classified as highly sedative, which include drugs like diphenhydramine, dimenhydrinate, promethazine, hydroxyzine. Then there are the drugs which are having a moderately sedative action, drugs like phenyramine, cyproheptadine, meclozine or meclizine, and we also have sinarizine, which is having a moderately sedative action. And then there are the drugs with mild sedative actions. Those which are there in this group are drugs like chlorpheniramine, we have dexchlorpheniramine, and we have triprolidine and clemastine. So these are the drugs with mild sedative action. So that is about the older generation. Then we have the second generation or the newer generation antihistaminics, which include drugs like fixofenadine, we have loratadine, we have desloratadine, we have cetirizine, levocetirizine, we have azilestine, mesolastine, ibastine, and we have ropatadine. So all these are the drugs which are included under the conventional antihistaminic drugs. Now, side effects of these drugs, they mainly cause sedation, which is a major side effect related to the older generation ones, and they cause impairment of the psychomotor performance. Therefore, these when the patient is taking these drugs, the patient has to be cautioned about driving vehicle or operating machinery which requires constant attention. The second generation antihistaminics are free of CNS effects, so they can be used in such conditions. Again, anticholinergic side effects are there with especially the first generation or the older antihistaminics. That is dryness of mouth, alteration of bowel movement, urinary hesitancy, and blurring of vision. So these are the anticholinergic side effects which are related to, especially to the first generation antihistaminics or the older generation antihistaminics. The second generation antihistaminics are those antihistaminics which are those H1 antihistaminics which have been marketed after 1980. Now these drugs, with these drugs, CNS depression is less. They cause less CNS depression, and therefore less of sedation is there with these drugs. Again, they do not have anticholinergic side effects, and also there are additional anti-allergic mechanisms with these drugs apart from histamine blockade. So the principal indications of these drugs are in case of allergic rhinitis and conjunctivitis. They control the sneezing, the runny nose in these conditions, and also the red watering itchy eyes, which are the symptoms in these conditions, allergic conditions. Then these drugs are useful in case of urticaria, atopic eczema. They are also useful in acute allergic reactions to various drugs and foods. So these are the major principal indications of the second generation H1 antihistaminics. Now coming to the uses, overall uses of the antihistaminic drugs. Now these uses are generally asked in the exams. What are the uses of the H1 antihistaminics when a full question is asked? So these drugs are useful in allergic disorders, which we have already seen, and also other conditions involving histamine. For example, in insect bite, where histamine may be released, or in case of IV poisoning. These drugs are also having a prophylactic value in blood or saline infusion induced rigors. So rigors which are caused because of the saline being induced or blood being induced. So again, these drugs can be used in such conditions. Then the pruritides, these are the major indications of the H1 antihistaminics. The older ones, especially like chlorpheniramine maleate and diphenhydramine, are the drugs which are commonly used in various in case of pruritus. Then in case of common cold, now these drugs, they cause a symptomatic relief in case of common cold. Again, motion sickness, these drugs are quite helpful in motion sickness. They prevent motion sickness when taken half an hour or 1 hour uh, before traveling. Again, promethazine, this drug is useful in vomiting of pregnancy or morning sickness. Again, in case of drug-induced or post-operative vomiting, this drug is quite helpful. Promethazine will control the vomiting in such cases. The other indication of the H1 antihistaminics is in case of vertigo, where generally we use the drug sinarizine. Then in case of pre-anesthetic medication, promethazine is one of the drugs which is used in the pre-anesthetic medication, which is given before different types of surgery. Cough is again one of the uses. It is used as antitussive drug. It gives symptomatic relief. It is one of the ingredients. It is included as one of the ingredients in the various cough preparations which are available in the market, either chlorpheniramine or diphenhydramine or promethazine. So any of these ingredients may be included in the various cough preparations which are available in the market. Parkinsonism, again, this drug promethazine gives a symptomatic relief uh, to the patient in case of Parkinsonism. Acute muscle dystonias, which may be caused due to antiemetic or antipsychotic. So here drugs like promethazine and hydroxyzine will control the acute muscle dystonias due to these drugs. Last and but not the least, these drugs are used as putative hypnotic, and they also have a anxiolytic action. So that's it about these drugs. Thank you. So I
Mm,
hope
tha-
understood.
yeah, thank you, Nazima ma'am, for sharing your expertise in pharmacology. On behalf of MUHS and Rapid Revision team, thank you so much. You have covered the maximum topic in a short duration. Thank you so much, ma'am. Great lecture.
Thank you, sir.
Now I invite Dr. Manjusha Borde ma'am from Sihagat Dental College to continue the session.
Yes, sir. Sir, I'm not able to share the slide. Could you please make me co-host?
Yeah, we'll look after it. Yeah, give some time. Manjusha ma'am.
Yes, yes, sir. I'm
Uh,
audible?
yeah.
Huh.
You have shared your slides to university.
Yes, yes, sir.
Uh,
It is visible?
yes, now it is visible, ma'am. Yeah.
Good afternoon, everyone. Myself, Dr. Manjusha, Assistant Professor and In charge HOD, Department of Pharmacology, Sihagat Dental College and Hospital, Pune. At this period of pandemic, I take this opportunity of taking rapid revision session on topic drugs acting on central nervous system and gastrointestinal tract. I hope this session would be definitely help for your upcoming exam, and at the end of session, I'm sure you will be able to answer the frequently asked short answer as well as the long answer questions. Drugs acting on central nervous system. Drugs acting on central nervous system have a major therapeutic and clinical importance. Drug can produce the diverse pharmacological and psychological effects such as induction of anesthesia, relief of pain, prevention of seizure, reduction of anxiety, and treatment of depression. What are the sedative and hypnotics? Sedative are the drugs that reduce the excitations, cause the drowsiness, and calm the person without inducing the sleep. Whereas the hypnotics are the drugs that produces the sleep which resemble into the natural sleep. This is a classification of sedative and hypnotic drugs. We have benzodiazepine. This benzodiazepine again classified into three categories. Hypnotics like a diazepam, flurazepam, nitrazepam, temazepam. Anti-anxiety like a diazepam, alprazolam, lorazepam, and anticonvulsant like a diazepam and lorazepam. We have barbiturate, long-acting, short-acting, and ultra-short-acting barbiturate. Long-acting like a phenobarbital, meflobarbital, short-acting pentobarbital, butabarbital, and ultra-short-acting like a thiopentane. Newer drugs like a zolpidem, zopiclone. Chemically, it is not, it is differed from the benzodiazepine, but the produces effect through the GABA and produces the hypnotic type of the effect with minimal anti-anxiety and anticonvulsant responses. And miscellaneous agent, melatonin, ramiltion, paraldehyde, chloraldehyde, etc. This is a GABA receptoric diagram. How this benzodiazepine and hypnotic drug produces the effect. GABA is the inhibitory neurotransmitter of the central nervous system. Benzodiazepine, non-benzodiazepine, and barbiturate bind to the GABA chloride channel. Benzodiazepine and non-benzodiazepine leads to increase the duration of frequency of a chloride channel, whereas the barbiturate increase the duration of chloride channel opening in neuron leads to the hyperpolarizations and CNS depression. This is the therapeutic uses of sedative and hypnotic. Sedative and hypnotic drug produces the sleep and also increase the sleep time. Also, benzodiazepine used as a diagnosis purpose and many more minor operative surgical procedures like the fracture reductions or endoscopic type. These sedative hypnotic drugs like the midazolam or the diazepam used as a pre-anesthetic medications and IV anesthesia because of their sedations and anxiolytic and amnesic properties. Diazepam responsible to produces the reduce the muscle tone and use as a skeletal muscle relaxant by the central mechanism. Sedative hypnotic drugs also used in alcohol withdrawal symptoms or the drug withdrawal cases to reduce the intensity of the drug withdrawal symptoms. Sedative hypnotic drugs have the selective anticonvulsant effect. In case of the status epileptics, IV diazepam is the first drug of choice. And in upset seizure, ethosuxinamide is the first drug of choice and also used in treatment of anxiety and management of insomnia. Barbiturate is the phenobarbital, which is a microsomal enzyme inducer drugs. This microsomal enzyme inducer drugs responsible to enhance the synthesis of gluconyl transferase, which required the metabolism of bilirubin cases so that it helped to clear the bilirubin in a neonate. Benzodiazepine have the wide margin of safety. They are generally well tolerated, but also produces the drowsiness, confusion, vertigo, amnesia, lethargy, weakness, headache, blood vision. Day-night sedation is more common and impairment in motor coordination. So that while driving should not be used the benzodiazepine like a diazepam, lorazepam type of the drugs. Dry mouth, sweating is more common. If the repeated or long-term administration of benzodiazepine may cause the tolerance, cross-tolerance and dependence type of the effect and also produces the drug abuse. If it is used in a newborn cases or if it is used in mother, then it causes the respiratory depressions and floppy baby syndrome type of the effect in newborn. This is most frequently asked question in Viva. Why the benzodiazepine are preferred over the barbiturate as a sedative hypnotics? Benzodiazepine induces the sleep which is more closely resembling to the natural sleep and less hangover as compared to the barbiturate. Benzodiazepine have the highest safety margin and lower abuse liability as compared to the barbiturate. And in case of the overdose, we have a benzodiazepine antagonistic agent like the fumazoline. We can use the fumazoline to reverse the symptoms like the hypnosis or cognitive caused by the benzodiazepine. And repeated administrations of benzodiazepine may cause the tolerance, psychological or physiological dependence or withdrawal symptoms is much more less as compared to the barbiturate. And one more important concept related to the benzodiazepine is that benzodiazepine do not cause the microsomal enzyme induction. So there is no increase in drug blood level of another drug. So there is less drug-drug interaction. Antiepileptic drug. This is the next important topic in CNS and mostly asks short note on status epilepticus. Then what is meant by epilepsy? Epilepsy is also, it is the group of disorders of CNS characterized by the seizure with or without convulsion and with a sensory or psychiatric phenomena. And seizure is the brief episode of loss or disturbances of the consciousness. Broadly, epilepsy are categorized into two groups, generalized seizure and partial seizure. This generalized seizure again categorized into three groups, like a generalized tonic-clonic seizure means grand mal epilepsy, obscene seizure, myoclonic seizure, simple partial seizure, and complex partial seizure in classified into partial seizure. One more important concept related to epilepsy is the status epilepticus. It is the neurological medical emergency which is characterized by the recurrent attack of tonic-clonic seizure without the recovery of consciousness in between the attack. We'll see the treatment plan afterward. On the basis of mechanism of action, these anti-epileptic drugs are classified into three categories. Drug which decrease the neuronal excitability by delaying the recovery from the sodium channel inactivations, like a phenantoin, carbamazepine, valproate, lamotrigine, topiramate. Then drugs which decrease the low threshold calcium current, like the ethosuxinamide or valproate. Drug which enhance the inhibitions through the GABA is the barbiturate, benzodiazepine, valproate. You all are aware about the barbiturate and benzodiazepine mechanism of actions. They bind to the GABA receptoric chloride channel, and benzodiazepine leads to increase the opening of a chloride channel, and barbiturate leads to increase the duration of opening of a chloride channel and result in hyperpolarization. These anti-epileptic drugs act by one or more mechanisms like a phenantoin, carbamazepine, oxycarbamazepine, sodium valproate, lamotrigine, topiramate. These drugs bind to the voltage-dependent sodium channel and prevent the further entry of sodium ion into neuron and cause the membrane stabilizing type of the effect, and also inhibit the generation of repeated action potential and reduce the spread of seizuric attack. Some more drugs are the ethosuxinamide, which is the best drug of choice for the obscene seizure, and valproate. They are produces the effect by the blocking of low threshold calcium current, and barbiturate, benzodiazepine, valproate also produces the effect by blocking of inhibition, enhance the inhibition by the GABAergic receptoric mechanism. This chart summarizes the different types of epilepsy, first choice of the drugs and alternative drugs. We have tonic-clonic seizure in grand mal epilepsy. In this case, first line of drug treatment is the carbamazepine, phenobarbital, phenantoin, valproic acid, and alternative drugs is the trimologine, topiramate, pramintone. Simple partial seizure, in this case, simple partial and complex partial seizure, first drug of choice is the carbamazepine, phenantoin, valproic acid. And alternative drugs or second line drug is the gabapentin, lamotrigine. In obscene seizure, ethosuxinamide is the best drug of choice or considered as a first drug of choice, and alternative drug is the clonazepam. Myoclonic seizure, in this case, Valproic acid is the first drug of choice, and clonazepam is the alternative drug of choice. And we'll discuss the status epilepticus step-by-step treatment plan. Coming to the therapeutic uses of phenantoin, this phenantoin considered as a major anti-epileptic drugs. It is not a CNS depressant, but at the therapeutic dose, it causes the sedation, and at a toxic dose, it causes the excitations. Phenantoin is used as a first-line drug treatment for the grand mal epilepsy, simple partial seizure, complex partial seizure as a first choice of the drugs. It is not at all used in absence seizure. It is also play an important role in a status epilepticus as an alternative to diazepam. Phenantoin also used in treatment of digitalis caused cardiac arrhythmias, and also the second line drug after carbamazepine for the treatment of the trigeminal neuralgia. Adverse effect of phenantoin depends on the dose, duration of responses, and route of administrations. Repeated administration of phenantoin may cause the hypertrophy and hyperplasia of the gum. It is an important side effect related to the dentistry. Hypersensitivity reaction is more common. Hirsutism is mainly caused due to increase of androgen secretions. Endocrine side effect like the hyperglycemia, osteomalacia, and hypocalcemia. Osteomalacia and hypocalcemia occurs due to the increase the metabolism of vitamin D and calcium. Megaloblastic anemia is more common because of interference with the metabolism and excretion of a folate. If it is used in a pregnancy, it also causes the fetal hedontoin syndrome, which is characterized by the cleft lip, cleft palate, and digital hypoplasia. And in higher concentration or the higher doses, phenantoin also causes the GI-related side effect like the nausea, vomiting, epigastric pain. And one more important side effect with a higher concentration in CNS related is the cerebral vestibular manifestations, which is characterized by the ataxia, dizziness, mental crowding, drowsiness, nystagmus type of the effect. And only in a IV administration, it causes the hypotensions and cardiac arrhythmia in a higher concentrations. This slide summarizes the treatment plan of status epilepticus. This status epilepticus is the neurological emergency conditions which is characterized by the recurrent attack of the tonic-clonic seizures. In this case, lorazepam is the first drug of choice, 0.1 mg per kg IV slow administrations, or diazepam 10 mg IV slow administration, and repeat after 10 minutes if necessary. This lorazepam produces the sustained anticonvulsion effect as compared to the diazepam. So lorazepam and diazepam considered as a first line of treatment for the status epilepticus. Then phosphinantoin in 20 mg per kg IV can be recommended. This under the supervision of, under the monitoring of ECG. Second, if it is not controlled or if it is not respond to the phosphinantoin drugs, then phenantoin 20 mg per kg IV infusion can be recommended. Because phosphinantoin is also the slow acting drugs. And another is the barbiturate like a phenobarbital 10 to 15 mg per kg IV infusion can be recommended. It is also the slow acting drug and used as an alternative to slow acting drug treatment. If it is not control the seizuric attack, then GA, general anesthetic with IV midazolam or propofol can be given to the patients. And finally, general measures are the play an important role, the maintenance of the airway, blood pressure, fluid and electrolyte balance. After the stoppage of drug seizures, long-term anti-epileptic drugs are needed. Most important topic as in a dentistry is the anesthetic. This anesthetic broadly categorized into two groups is the general anesthetics and the local anesthetics. General anesthetics means the drugs which produces the reversible loss of sensation, especially for the pain and consequence. which produces the analgesia, amnesia, immobility, and muscle relaxations, and loss of reflexes. One more important terminology related to anesthesia is the balance anesthesia. It is the combination of the drug used to produce as the amnesia, muscle relaxations, or the sleep analgesic effect and loss of reflex state type of the effect. Whereas the local anesthetic is the drug cause the reversible loss of sensory perceptions, especially for the pain in restricted area of a body. It blocks the generation and conduction of nerve impulses and produces the effect. Let's compare the general anesthetic and local anesthetics. The general anesthetic main site of the general anesthetic is the CNS, and local anesthetics act on the peripheral nerve. Whole body involved in a general anesthetic, whereas the restricted area or the site of administration involved in a local anesthetic. If it is given to the patient, general anesthetic will be given to the patients, then vital organ monitoring is the play an important role, but it is not that much important with a local anesthetic. General anesthetic mostly preferred for the major surgical cases. For the minor surgical cases, mostly the local anesthetic can be used. General anesthetic on the basis of route of administration broadly classified into two groups, inhalational and parenteral general anesthetic. This inhalational, we have volatile drugs and gases like ether, isoflurane, desflurane, halothane, infurane, and gases nitrous oxide and cyclopropane. We have inducing agents like a thiopentane sodium, propofol, and etomidate. Slower acting agent like a benzodiazepine means midazolam, diazepam, lorazepam. Dissociative anesthetic agents like the ketamine and opioid analgesic or neuroleptic agents. One more important concept related to anesthesia is the pre-anesthetic medications. Prior to the anesthesia, certain drugs are administered in order to make the anesthesia safe and pleasant. It is called as a pre-anesthetic medications. To produce the sedation, mostly sedative hypnotic drugs like a diazepam, lorazepam, and midazolam can be preferred as a pre-anesthetic medications. To relieve the post and pre-operative pain, in this case opioid analgesics like a morphine and pethidine can be used as a pre-anesthetic medication. Some anticholinergic drugs like atropine or glycopyrrolate, this is used to reduce the salivary or the bronchial secretions, and some antiemetic drugs like a metaclopramide, domperidone or ondansetron can be used to control the vomiting. And some H2 blockers like the ranitidine or antihistaminic also used as a pre-anesthetic medication to reduce the gastric acid secretion, and as such antihistaminic drugs has a property of the sedations and anticholinergic and antiemetic property. Local anesthetic agent classified into four main categories. Injectable local anesthetic agent, we have low potency, short duration of drugs. Intermediate potency, long intermediate duration of a drugs like a lidocaine. High potency and longer duration of a drug, tetracycline, buprenorphine type of the agents. We have surface anesthesia like a soluble as well as the insoluble, cocaine, lidocaine, tetracycline, and insoluble benzocaine, butyl aminobenzocaine. Synthetic non-nitrogenous compound also used as a local anesthetic agent like the benzyl alcohol, and miscellaneous drugs with a local anesthetic which is commonly used in household cases like a clove oil. Then some physical method also consider or produces the local anesthetic type of the effect like the refrigeration, application of eye, and ethyl alcohol spray. This diagrammatic representation show the how this local anesthetic drugs produces the effect. Site of local anesthetic is the cell membrane cell. In this case, local anesthetic produces the effect by acting or blocking of the sodium voltage gated sodium channel, thereby reduce or inhibit the entry of the sodium ion, and also reduces the generation of action potential and result in formation of a membrane stabilizing type of the effect. By this mechanism, local anesthetic drugs produces the effect, means normally it inhibit the generation and conduction of nerve impulses. There are various techniques and uses of the local anesthetic. We have surface anesthesia, in this case only local anesthetic agent applied on the mucous membrane. Infiltration anesthetics, which in this case local anesthetic directly injected into the tissue, it blocks the sensory nerve ending. We have conduction block. There are two types of the conduction blocks, field block anesthesia and nerve block anesthesia. In dental practice, mostly use the field block anesthetic techniques. Field block anesthesia, in this case, local anesthetic directly injected near the apex of the tooth, and nerve block anesthesia, in this case, very injected the local anesthetic very close or around the peripheral nerve or nerve plexus. We have spinal anesthesia. In this case, local anesthetic injected in subarachnoid space to anesthetize the spinal root. Epidural anesthesia, local anesthetic injected in epidural space. It is most commonly preferred in obstructive analgesic purpose. And last one is the Baer blocks. This is mostly used in anesthetizing the orthopedic surgical cases on the upper limb. This is the most frequently asked question in Viva. What are the advantage of combination of adrenaline to lignocaine? This adrenaline is the vasoconstrictor agent. Most commonly preferred this combination of adrenaline to lignocaine in dental practice. What is the advantage of this combination? It prolongs the duration of action of local anesthetic by decrease their rate of absorption from the site of systemic circulations, and also increase the intensity of the nerve block, and adrenaline provide the bloodless field for the surgical cases. This combination reduces the systemic toxicity of local anesthetic, so that this combination most commonly preferred in a dental practice. But simultaneously it share the disadvantage of these combinations, because this combination intense vasospasm and ischemia in the tissue with the end of arteries may cause the gangrene type of the effect in a finger, toes, or the penis or the tip of the nose. Then absorption of adrenaline may cause the systemic toxicity. Hence, it is contraindicated in a patient with a cardiovascular disorders, because adrenaline may cause the tachycardic or increased blood pressures type of the effect, and may delay the wound healing because of reduce the blood supply to the particular area. Most important topic is the analgesic. Most frequently asked the LAQ from this topic, analgesic. Analgesic are the drugs which relieve the pain sensation without loss of consciousness and without modifying the underlying cause. We have two types of analgesic, is the opioid analgesic and non-opioid analgesic. Opioid analgesic is also called as a narcotic analgesic and morphine-like analgesic. Non-opioid analgesic is the non-narcotic type and aspirin-like analgesic. It is also called as a non-steroidal anti-inflammatory drugs, means NSAIDs. This opioid analgesics act primarily at the level of spinal cord and brain and exert their therapeutic effect by mimicking the action of endogenous opioid peptides and on the opioid receptoric mechanisms. It is a very potent analgesic and induces the variable degree of sedations, and therefore it is called as a narcotic analgesic. Morphine is the potent opioid analgesic. On the basis of the source, these opioid analgesics are classified into three main categories. Natural opium alkaloid is the morphine, codeine, nascaphine. Semi-synthetic derivatives like the heroin, folcodeine, and oxymorphine. Synthetic opioids is the pethidine, fentanyl, diphenoxylate, tramadol, loperamide, and dextroprofaxifen. These are the synthetic type of the opioids alkaloid. Morphine and other morphine congener produces the effect by acting on the opioid receptoric mechanism. There are three types of opioid receptor: mu receptor, kappa receptor, and delta receptor. These are the G protein coupled receptor. This stimulation of opioid receptor inhibit the adenyl cyclase and decrease the cyclic AMP formations, which lead to facilitate the opening of a chloride channel and result in hyperpolarization of memory. This lead to decrease the release of a neurotransmitter or inhibit the release of neurotransmitter, which is involved in a pain transmission pathway. Adverse effect of morphine. Morphine produces the wide range of adverse effect. It produces the nausea, vomiting, constipation type of the GI ADRs. Dizziness, mental corroding is more common because it belongs to the narcotic categories. Respiratory depression, it is one of the cause of death in acute morphine poisoning cases. It's one of the most important cause of death in acute morphine poisoning cases. Urine retentions, bronchospasm is more common. Hypotensions due to the vasodilatations, and morphine responsible to is the histamine responsible to release the histamine, so that the allergic reaction at the site of injection is more common skin rash and pruritus. In rare case, IV administrations may cause the anaphylactic shock also. Repeated and long duration of the administration may cause the tolerance with some effect like tolerance with analgesia, sedation, respiratory depression, euphoria, but not produces the tolerance with some side effect like meiosis or the constipations. And morphine also produces the psychological and physiological dependence with a sudden cessation produces the withdrawal symptoms also. This is the acute morphine poisoning. This acute morphine poisonings may be accidental, suicidal or homicidal. Lethal dose in case of acute morphine poisoning is the 250 mg. In this case, we have specific antidotes for the acute morphine poisoning is the naloxone. Naloxone is the pure form of the opioid antagonist. Naloxone 0.4 to 0.8 mg IV every 15 to 20 minutes is recommended because naloxone is the shorter duration of responses, so repeated administration is required in case of the poisoning cases. Therapeutic uses of morphine and its congeners. Morphine is the potent analgesic. Morphine and other opioids mainly used in a moderate to severe form of the painful conditions such as the acute myocardial infarctions, fractures, burns, terminal cases of the cancer, and post-operative pain. Morphine and pethidine is also used as a pre-anesthetic medication because of their sedation, anesthesia, sedative and anxiolytic effect. Also used in treatment of acute left ventricular failure. Morphine responsible to control or relief of breathlessness associated with acute left ventricular failure and acute pulmonary edema cases. Codeine, holcodeine, and dextromethorphan. These are the drugs used for the suppression of coughs. And diphenoxylate and loperamide is the drug of choice for the symptomatic relief for the diarrheal cases. And also pethidine is the drug used for as a post anesthetic shivering cases. Mostly pethidine can be recommended. This chart summarizes the different properties of commonly used opioids. We have morphine, which is a potent analgesic. Then methadone, similar to the morphine. Pethidine, similar to the morphine, and 1/10 as a potent analgesic. Fentanyl, codeine, pentazocine, then tramadol. Is the non-steroidal anti-inflammatory drugs is the commonly used as a over-the-counter drugs. This non-steroidal anti-inflammatory drug has an analgesic, antipyretic, and anti-inflammatory actions. In comparison with a morphine, this non-steroidal anti-inflammatory drugs, also called as a non-narcotics and aspirin-like of agent. This aspirin-like of agent is a weaker analgesic and do not depress the CNS, do not produces the physical dependence, and no abuse liability. Mostly a long answer question asked on the non-steroidal anti-inflammatory drugs. Classify the non-steroidal anti-inflammatory drugs and mechanism of actions, ADR, and therapeutic applications of aspirin. These non-steroidal anti-inflammatory drugs are broadly classified into four categories. Non-selective COX inhibitions like the aspirin, phenylbutazone, ibuprofen, mefenamic acids. Preferential COX-2 inhibitors is the diclofenac, nimesulide, etodolac. Selective COX inhibitions is the celecoxib, paracoxib, heterocoxib. Analgesic antipyretic with a poor anti-inflammatory actions is the paracetamol and metamizole. This slide summarizes the mechanism of action of non-steroidal anti-inflammatory drugs. During the inflammations, arachidonic acid is liberated from the phospholipid membrane and which is converted to the prostaglandin with the help of the cyclooxygenase enzyme. These non-steroidal anti-inflammatory drugs inhibit the prostaglandin synthesis by the inhibitions of the cyclooxygenase enzyme. This aspirin produces the irreversible inhibitions of the cyclooxygenase enzyme, whereas the rest of other non-steroidal anti-inflammatory drug produces the reversible inhibition of a cyclooxygenase enzyme. Therapeutic uses of non-steroidal anti-inflammatory drugs are non-steroidal anti-inflammatory drugs considered as a potent analgesic for the various type of the conditions like the headache, backache, myalgia, neuralgia, toothache, dysmenorrhea. It also responsible to reduce the fever obtained from the various origin. Is used as a anti-inflammatory purpose like the arthritis and fibromyalgia. Non-steroidal anti-inflammatory drugs like aspirin considered as a first drug of choice for the acute rheumatoid arthritis and acute rheumatoid fever and acute rheumatoid arthritis. Antiplatelet effect of low dose of aspirin can be used in a prophylactic purpose of a thromboembolic disorders like the myocardial infarctions and transient ischemic attack. In this case, also preferred the low dose of aspirin because low dose of aspirin produces the antiplatelet activity. In osteoarthritis condition, also aspirin considered as a second line of the drugs. Paracetamol can be preferred for this condition. Apart from the various type of the miscellaneous condition, also preferred the non-steroidal anti-inflammatory drugs like use in a closer patent of ductus arteriosus in newborns. It also, most of the studies suggested that aspirin recommended in a prevention of the colon and renal cancers to delay the labors because of inhibitions of the prostaglandin synthesis, and eclampsia in this case also preferred the aspirin. This non-steroidal anti-inflammatory drug like aspirin also used as a keratolytic agents, mild antiseptic and fungistatic purpose. Coming to the adverse effect of the aspirin, because of inhibitions of the prostaglandin synthesis, it produces the broadly gastrointestinal related side effect like the epigastric distress, nausea, vomiting, gastrointestinal mucosal damaging effect, and peptic. It also produces the hypersensitivity reactions. Hemolytic anemia is in people with a glucose 6-PD deficiency. Salicylism is the one of the most are caused by the inflammatory doses because the in a analgesic doses tolerable form of the AD are caused by the aspirin, but for the inflammatory dose it may cause the various type of the side effects like the salicylism, which is characterized by the dizziness, vertigo, tinnitus, reversible impairment of the hearing and visions and electrolyte imbalance. One more most important concept is the Rett syndrome, which is mostly asked in Viva and MCQ. This, if the aspirin is given in a children with a viral fever, in this case, cause the Rett syndrome, which is characterized by the hepatic damage and encephalopathy. Inhibition of PG synthesis thereby delay the onset of the labors and increase the chances of the postpartum hemorrhagic attack. Long-term administration also cause the reversible damage of the kidney damaging type of the effect and may cause the analgesic nephropathy type of the syndrome. Let's compare the aspirin and morphine. Aspirin is the non-steroidal anti-inflammatory drugs and morphine is the opioid analgesic. As a chemistry point of view, it is a salicylic acid and morphine is the opioid analgesic, which is obtained from the opium of Papaver somnifera. Aspirin producer has the analgesic, antipyretic and anti-inflammatory as well as antiplatelet activity, but morphine produces only analgesic effect. Euphoria, sedation, abuse potential is more common with aspirin, but more common with morphine, but not with the aspirin. Aspirin produces the respiratory stimulation type of the effect, whereas the morphine produces the respiratory depression type of the effect. Aspirin produces the effect by the inhibition of the prostaglandin synthesis by inhibiting the cyclooxygenase enzyme, whereas the morphine produces the stimulatory effect on the opioid receptor, which is a G protein coupled receptors. In a poisoning cases, with a morphine, we have antidotes, is the naloxone, but with the aspirin, we have no antidotes. Especially aspirin preferred as an analgesic for the various type of the conditions, secondary prophylaxis of the myocardial infarctions and anti-rheumatic purpose. But morphine produces the potent analgesic effect, anesthetic purpose, and diarrheal and cough, treatment of the diarrhea and cough. This chart summarizes the properties of commonly used non-steroidal anti-inflammatory drugs. We have aspirin, paracetamol, diclofenac, pyrizolam, phenylbutazone, endomethacin, and ibuprofen. Now we'll discuss with our next system is the drugs acting on the gastrointestinal system. There are different type of the acid peptic diseases or disorders like the duodenal ulcer, gastric ulcer, trace ulcer, or drug-induced type of the ulcer is non-steroidal anti-inflammatory drug-induced type of the ulcer. This ulcer mainly caused by the imbalance between the acid pepsin secretions and the mucosal defense mechanism. And one of the causative agent for the peptic ulcer is the H. pylori infections. We have drugs to reduce the gastric acid secretion used in treatment of peptic ulcer. We have H2 antihistaminics like a cimetidine, formitidine, ranitidine, roxetidine, which is competitively block the histaminic H2 receptor and produces the effect. Proton pump inhibitors like omeprazole, pantoprazole, lansoprazole, tabeprazole, which is responsible to inhibit the proton pump, potassium ATPase pump. And anticholinergic drugs, also called as the antimuscarinic drugs like the palansipine, talansipine, oxyphenone, produces the effect on the muscarinic receptoric mechanism. These all category of the drugs responsible to reduce the gastric acid secretion and helpful in a peptic ulcer condition. We have drugs that neutralize the gastric acid, means antacid. We have two types of the antacids, systemic antacid like the sodium bicarbonate and non-systemic antacid like the magnesium hydroxide, magnesium trisilicate, aluminum hydroxide. Ulcer protective drug like the sucralfate and CBS, means the colloidal bismuth substrate, also produces the protective response on the ulcerative parts. And other drugs and anti-H. pylori drugs like the antibiotics, amoxicillin, metronidazole, tinidazole, clarithromycin, and broad-spectrum antibiotics like the tetracyclines. Missing of slides. Key point for the dentistry is the repeated use of the benzodiazepine can cause the drug tolerance and dependence. Ketamine is the dissociative anesthetics, should be avoided in an epileptic because it may cause or precipitate the seizure, and in patient with a history of psychiatric disorders. The combined preparation of vasoconstrictor and local anesthetic should be avoided in a patient with hypertension, cardiovascular diseases, or arrhythmias or uncontrolled hyperthyroidism, because this Adrenaline causes the systemic toxicity. Morphine is contraindicated in elderly and patient with head injury because morphine are more prone to produces the respiratory depressions, and in head injury also contraindicated because there is mental crowding type of the morphine effect may cause the disturbances in assessing of the progress of the head injury in patients. Patient on the aspirin should stop 5 to 7 days before the dental procedures because of the antiplatelet activity of the aspirin, and there is a cause of the aspirin cause the bleeding tendency. So before the any dental procedure, 5 to 7 days before stop the aspirin. Dentists should be carefully in using the non-steroidal anti-inflammatory drugs and other gastric irritant in a patient suffering from the acid peptic disorders. This is one of the slide which summarize the mechanism of actions of how these drugs act in a peptic ulcers. This gastric acid regulations, gastric acid secretion is regulated by the vagus gastrin and locally release the histamine, which is act on own receptoric mechanism, and this activated the proton pump, potassium ATPase, hydrogen potassium ATPase pump, which is a final pathway for the secretion of the gastric acid secretions, which is blocked by the proton pump inhibitors like the omeprazole. This proton pump is the most efficient inhibitors of the gastric acid secretions and commonly used cause the ADR like the GI disturbances, dizziness, drowsiness. Long-term administration may cause the vitamin B12 deficiency and also used in a treatment of drug-induced type of the ulcer and gastroesophageal reflux diseases and JD syndrome associated with the gastric secretion tumor. Thank you, sir. Hello.
Hello.
Yes, sir.
Thank you, Manjusha madam, for participating in this session. Now everyone will leave this group and rejoin the new group. The link is already sent in rapid revision WhatsApp group. Mutalik sir will take the next lecture after joining we all.
Yes, sir.
Thank you so much, Manjusha madam. Thank you on behalf of MUHS and team Rapid Revision. Thank you.
Stop sharing. ऍक्च्युली माझं काय झालं माहितीये का, शेवटची स्लाइड पहिले येऊन गेली की पॉइंट फॉर द डेंटिस्ट्रीची आणि नंतर मग ते आलं, कळलंच नाही मला कसं शेअर झालं.
ती दुसरी सुरू केली का आता? ही संपली का? जस्ट संपली. दुसरी सुरू केली का? दुसरा स्पीकर सुरू पाहिजे. अरे थांबा, ही मीटिंग सुरू केली का? नाही, ही संपली ना मागची माझ्याकडची. मग ही बंद करा ना. तेच सांगतोय मी तुम्हाला. पुढे गेले यार. ही संपली ना, ही एंड करायचं आता.